I know. I know it takes a lot for folks to be here on a weekend, especially that things are getting better now with our weather, although today is kind of a crummy day. But welcome to the second annual High Five to HIPEC education event. I'm Harveshp Mogal for those of you that don't know me. I started here at Fred Hutch and UW Medicine about almost 3 years now. Wow, time flies. I direct the HIPEC program, and along with Dr. Stacey Cohen, who you'll be seeing shortly, co-lead the HIPEC multi-D clinic at Fred Hutch Cancer Center. And when we started this program, we noticed that there was a lot of dearth in terms of information for patients that have peritoneal cancers from different types of tumors. We not only noticed that there was dearth of information, we noticed that there was a lot of confusion. There was a lot of anxiety that patients had in terms of next steps, because a lot of times they got diagnosed in centers that didn't really know what to do. And so our efforts right from the inception was to try and build a sort of an education event where we can disseminate more information to folks, especially in the Pacific Northwest, on peritoneal cancers in general and different treatments for different types of peritoneal cancer, so that folks know that even though these are rare cancers, the options are limited, that we have a facility there is a facility in their backyard that does treatment for these types of tumors. So that was kind of the impetus to start this event, and to also spread awareness for those folks that are just looking for information in general. So that was the impetus for starting this event. Dr. Stacey Cohen is an associate professor at UW Medicine and Fred Hutch Cancer Center, who co-leads the HIPEC multi-D program with us at Fred Hutch, and unfortunately is not able to join us personally, in person rather, but she was joining us virtually. She was at a big national conference, gathering all the important information that we need for cutting edge advances in treatments for patients. And unfortunately, she fell victim to COVID. And so she's been, I know, she's been really nice, kind to join the conference virtually. She's like, I'm going to give my talk, but she won't be with us in person. But, she's going to be talking shortly after me. And then we have a few other people that are going to give talks today. Let me see if I can advance. Yeah, so we'll start with some talks. I'll be just talking on peritoneal cancers in general. Dr. Cohen will talk a little bit about colon cancer and systemic treatment or chemotherapy for patients. We have Dr. Goff, who is the chair of OBGYN at UW Medicine, who participated in our event last year, who will be talking a little bit about the role of HIPEC in ovarian cancer and peritoneal metastasis. I have the pleasure of introducing a new faculty member this year, Dr. Sharib, who will talk a little bit about mesothelioma. And then we have Kerry, our dietitian, who leads the dietitian program at Fred Hutch, who is we're fortunate is joining us today to talk about the role of nutrition. We have Kathy Plakovic, who will talk a little bit about palliative care. We have one of our patients who has been kind enough and gracious enough to come here to share their story, because I think that's really important for a lot of you that have sort of a shared story, or at least a journey. And then we have a couple of people from a couple of very special organizations. One is PMP Pals, and one is the ACPMP Research Foundation, who will talk to you a little bit about the work they're doing in this space. And then lastly, we'll talk a little bit about the trials that we're running at Fred Hutch. And then we'll finish with a photo op, which I'm hoping everybody will stay for, because we really want to get a good photo. So just for everybody's information. This event is being recorded. If you have questions, there will be a little bit of time at the end of each speaker's talk to ask some questions. For those who are attending in person, we have microphones, so please raise your hand and we'll bring the microphone to you so you can ask. Otherwise, the virtual attendees are not able to hear. And then for those of you that are participating virtually, the questions can be asked via chat, and one of us on the panel will moderate those questions and make sure that the relevant speakers are able to access them and answer them. If you do end up leaving the seminar accidentally or deliberately, or your cat or dog or somebody decides to photobomb or whatever, just join using the same link again. And then there's breakfast and coffee right across the hallway, so feel free to get up and grab. And then there's restrooms. If you go down just before the front desk, you make a left and you'll find restrooms there. So if there are no other questions, then we can go ahead and get started so that we can get this day going. Oh yeah, there are a couple of breaks. So let's just make sure that when there are breaks, obviously grab whatever you need to, but take this opportunity to network with people, providers, whoever else you'd like to say hi to. And I think that's it. Yeah. And there is a survey at the end that we would love for you to fill out, because we can't do this function and provide you the most benefit from it unless we know exactly what you want to hear from us. And we heavily rely on your perspective and your requirements and needs and wants to make this a better event every single year. Just for everybody's information, I think we have 143 folks that registered for the event this year. A lot of them are virtual attendees. So with that, I'll delve into the first talk. Okay, so this is going to be a generic talk that I'm going to give. A lot of you that have already had this treatment have heard this from me, but for those of you that haven't, this is a good overview of what to expect. We'll briefly talk about the cytoreduction and HIPEC procedure. We'll talk about the common indications we do it for, how we select our patients, and then just a brief overview of what to expect in terms of long-term outcomes. So a lot of patients, this is a fairly challenging and a little bit of a nuanced concept to understand what the peritoneum is, because that's primarily what we're dealing with when we're talking about peritoneal cancers. But the peritoneum, in essence, is the lining of the inside of the abdominal cavity. And it not only lines the abdominal cavity, but it also lines the outside surface of the organ. So the diagram to your left basically shows you a cross-section lengthwise of the body, and that blue line is the peritoneum that covers the organs, and the red line is the peritoneum that's covering the inside of the abdominal cavity. And the other diagram is basically a bread loaf or a cross-section of the abdomen showing pretty much the same thing. And it is this lining that tends to be affected in patients that have peritoneal metastases or peritoneal cancer. And how does this typically happen? Usually peritoneal cancers originate from an organ within the abdominal cavity, most frequently the appendix or the colon. Sometimes it can arise directly from the peritoneum in patients that have a disease entity called mesothelioma, the ovaries, the stomach, pretty much any of the organs inside the abdomen can cause peritoneal metastases. And when the cancer starts to breach the surface of the organ and the cells start to distribute within the lining, these cells then attach to different parts of the peritoneal cavity, invade and sort of set up home, so to speak, and then form bigger tumors. And eventually the abdomen, if left untreated, can become completely full of these tumors. And, unfortunately, in the absence of treatment, most patients will succumb to this very, very unfortunate advanced type of cancer. And so treatment is somewhat challenging. And we always tell folks that at the end of the day, what you want to do, especially for those that have just heard this news, is to go to a referral center or a cancer center that really specializes in the treatment of patients with peritoneal metastasis. This is a brief slide. The caveat here is that this is specifically for colon cancer. So if you don't have colon cancer, this doesn't really directly apply to you, but it just gives you an idea of how challenging this problem is. For example, in colon cancer, patients can have metastasis to the lungs or the liver or the peritoneum, and sometimes two of those three or all three. And if you see this is what we call a survival curve, this curve that you're seeing up, it basically plots time against the number of patients that start at the beginning of the study. And what's important to remember is that you have to look at two things: how steep the curve is, as well as how high it stays above. When the curve is really steep, which means it's not a gradual slope, that's a bad thing, because then patients are dying much earlier of their disease. But when the curve is gradual and it stays high up, which means patients are staying alive for a long time, that's a good thing. And in colon cancer, we see that out of all the different sites of metastasis, peritoneal metastases are the worst. In fact, patients with peritoneal metastases in colon cancer do worse than those with both lung and liver metastases combined. So you can tell it's a really bad problem to have. And part of it is that by nature, peritoneal metastasis tends to be aggressive. And part of it is that chemotherapies don't penetrate the peritoneum very effectively, as they do with lung and liver and things like that. So this is where we come in. Dr. Cohen, for example, is the medical oncologist providing systemic treatment for peritoneal disease. And we as surgeons trying to provide surgical treatment for peritoneal disease. So a multi-pronged approach to try and maximize benefit from treatment. And so this is an example of what we do in the HIPEC procedure. While we call it the HIPEC procedure, really in essence, it has two parts. The first part is what we call cytoreduction, which is arguably the biggest and the most challenging part of the operation, where we have to go in and strip the lining of the abdomen, take out all the tumors. If we can't separate the tumors from the organs that are involved by them, then we have to take those organs out. And so that is the portion that takes arguably the most time, several hours, many a times. Most of the times we have to do what we call peritonectomies, or stripping of the lining in multiple areas. We remove the omentum, which is the fatty drape that almost always is involved by tumor, and then multiple organs, depending on how many areas are actually involved by tumor. And this is just a representative example of what we see. This is a patient of ours that had pseudomyxoma or appendiceal cancer, and you can see the entire abdomen is covered in tumor in multiple areas. Some of these tumors are fairly bulky, some of them are not. And so we have to strip this whole area. And for all of you who's had this procedure, you ask why the incision is so big and so invasive. And you see how we have to gain full exposure to the abdomen from the top to the bottom and all the quadrants. And, as you can imagine, this is what leads to a lot of, the side effects that a lot of you folks have to unfortunately deal with after surgery, including the discomfort and pain. And then when we go in, there are a couple of things that we try to assess and that we always assess. And these are things that you will come across frequently in your journey. Two concepts. One is of the disease burden, or the PCI score. So unlike other cancers, where cancer is just restricted to one organ, where we can just assess the burden of disease or the volume of disease, so to speak, based on the size of the tumor, in peritoneal disease, because it's so widely distributed and there are so many multiple tumors, there's no good way to just add all that up. It would be very challenging to have uniform assessment. And so we use a score called a PCI score, which is also called the Peritoneal Cancer Index. And what that does is we divide the abdomen into multiple quadrants, 9 specific quadrants, and then also the small intestine, because that can be involved by tumor, into 4 different quadrants. And each of these quadrants is allotted a score between 0 and 3, depending on how much tumor we see and how big those tumors are. And then we add all of this up, and then we eventually get a comprehensive score called the PCI score, which ranges from 0, which means there's no tumor at all in the peritoneum, to 39, which means this, pretty much every quadrant of the abdomen and all the bowel is involved. So the lower the score, the lesser the burden of disease, the higher score, the more the burden of disease. And this has correlation in terms of not only how successful we are in terms of doing an operation that's meaningful, but also it independently affects how patients do long-term, which is another way to say that patients with lower volume disease tend to do better in general than those patients that have much higher volume disease. And this is another thing to kind of drive home. That's why we like to try our best to get patients to come to us as soon as possible, because the PCI score of the burden of disease has an effect on long-term outcomes. And so the earlier we try to catch the disease process in its course, the better in terms of prognosis. The other thing we try to assess, which is again very important in terms of determining prognosis, is what we call the CC score. So not only is it important to know how much disease there is, but also at the end of the surgery and the HIPEC, how much do we actually leave behind? Not because we want to, but because we couldn't remove it all. And so the CC score comes into play then. It tells you what is the quantity of the disease left behind. And when we talk about doing these operations, our goal as surgeons is to try to get to that level of what we call CC0 or CC1. So either we have no tumor that we can visibly see that's left behind, or if we have very small tumor nodules that are less than 2.5 millimeters, then that's all. Unfortunately, when we start leaving more tumor behind, either because we can't remove it or it's too risky to remove, or if we were to remove it, it would very, very adversely affect a patient's quality of life, then we start getting into a part where we are not providing as much benefit to the surgery. There's still some role to do that in some patients, but certainly not as effective as we want it to be. So that is the goal. So after we finish this part of the operation, which is arguably the biggest part, then we go on to the HIPEC. We clump this procedure as the HIPEC procedure because it's easier for people to know that. But this is the second part of the operation, which is done during the same procedure, where we establish a circuit by putting in some special tubings in the abdomen and then temporarily closing the abdomen. And then those tubes are then connected to a circuit pump, which basically generates heat and heats up the chemotherapy up to a designated temperature. And then the chemo keeps flowing between the patient and the pump and back to the patient. So it circulates through the patient, gets heated up, circulates again for anywhere between 90 minutes to 2 hours, depending on, or 1 hour to 2 hours, depending on what type of chemo we're using. And this is another specialized part of the operation that has to be done in very controlled settings. We have what we call a perfusionist who deals specifically in pumps, kind of like the bypass pumps that people have when they have cardiac surgery or heart surgery, who monitor these pumps really closely, keep a close eye on the temperature and the flow rate, things like that. And after we do all of this, then we wash the abdomen out and we close you up. So the operation can take several hours, as you can imagine. And the reason we do this second part of the operation, in addition to removing all the tumors, is because we know that once the cancer has spread throughout the abdomen or in several parts of the abdomen, even if we've removed all the tumors, there may be microscopic tumor cells floating around. And so is there a way we can try to kill those microscopic tumor cells in the hope that we can prolong a patient's life or decrease the chance of tumor coming back? And that's where HIPEC comes in. And so the chemo in itself, when we circulate it through the abdomen, the advantage of that chemo is that it stays in the abdomen, so it's regional. And we can achieve some really high concentrations of that chemo medication. If we had to try to achieve those same concentrations in the abdomen by giving that chemo IV, we would have to use massive, massive doses, and those doses would not be tolerated by patients. But by using chemo that can stay within the abdomen, we can achieve those doses and try to kill as many cancer cells as possible. You know, the concentration of the chemotherapeutic drug in the abdomen can be 25 to 1,000 times higher than what is in the IV bloodstream at that time. So it's the heat also helps because it kills cancer cells directly, and it's also something that synergizes with the chemotherapy, as in there's an additive effect to the chemotherapeutic agent in achieving tumor cell kill. This is just to show you what type of agents we select. Some of you have questions about what type of chemotherapy medications we use. We try to use medications that have what we call a high molecular weight because we don't want much of that medicine to be absorbed into the bloodstream, right? We want it to stay in. And we use medications that basically have good penetration into tumor cells. And you can see cisplatin and mitomycin are the two common medications that actually have really good penetration into tumor cells. and they tend to stay in the peritoneum. This last column that says AUC IP-IV ratio, which means how much of the drug stays in the peritoneum versus how much gets absorbed, you want to see a really high number, right? Because you want less absorption into circulation and less overall side effects, and more stay within the peritoneum. So those two drugs have a really good efficacy when it comes to that. Some of the common cancers we treat with HIPEC, cytoreduction and HIPEC, is appendix cancers. So usually, by and large, to simplify it, it's two types of tumors. One is the mucinous variety called the pseudomyxoma peritonei, and then there's the appendiceal adenocarcinomas. And then there's colon cancer, peritoneal, mesothelioma, gastric cancer, ovarian cancer. And there are a few other types of rare tumors we do treat with HIPEC, but they're fairly rare. So haven't necessarily included them here today. So some of you have heard me say this, this is a big operation, lots of side effects or potential side effects that can happen. So when we subject patients to this operation, we want to be really careful that we provide them benefit and minimize their side effects, right? We don't want to provide an operation that's only going to be providing mostly side effects with very little benefit. So we have to really select our patients well. Again, another reason why folks should be going to specialized centers that do a lot of these procedures, that have oncologists that know chemotherapy regimens, when to intervene, how much chemo to give, all of those things, because this is a challenging operation to overcome. And a lot of you who are in support groups will tell me routinely that it's called the mother of all operations, right? And for a certain reason. So how do we select patients? Obviously, you have to be fit enough to undergo the surgery, and that goes without saying. Otherwise, you can't tolerate an operation that big. But there's this other concept that we loosely term tumor biology many a times, and it's somewhat of a difficult or challenging term to understand. Arguably, we don't understand that term very well many a times because there is no test to assess tumor biology, at least no direct test. But in essence, the tumor biology is the innate behavior of the cancer in every single patient. So every patient with a certain diagnosis, say pseudomyxoma or high-grade appendix or low-grade appendix, even though the diagnosis is the same, they may not behave the same. And the reason they don't behave the same is because each patient's tumor has somewhat of a unique signature or a stamp. And that stamp is called biology. But in essence, some of these tumors are quote unquote good tumors, and some of them are not good tumors. The good tumors are the ones that are more favorable in terms of their long-term outcome. The bad tumors are the ones that are not very favorable. And you may ask, why do we select patients that way and not provide treatment to everybody? Because we've known over time that if we try and do these procedures in patients that have relatively poor or bad or unfavorable biology, we almost always run into problems. And unfortunately, many a times we have patients that their tumors come back much faster. And so it's a hard balance sometimes, because we have younger patients, we have patients who've tried everything, who are super motivated. And it's a hard balance sometimes to strike when you're fighting that tumor biology, but at the same time, you're trying to balance the other risks and trying to give a patient the best possible outcome and every possible chance they can in beating their cancer. And that's, again, a very nuanced discussion to be had with your clinicians, with your medical oncologist, with your surgeon, in terms of where the benefit of the operation will really lie, and are there other options that should be explored rather than surgery? Because just because you can do an operation, that doesn't necessarily mean it's the right thing for a patient. And we think this biology is driven a lot by the genetic profile of the tumor. I won't go into details, but that's where we think it is. And so at the end of the day, we want to assess patients with good biology who can tolerate surgery. And we want to also make sure that folks that we are selecting, we can achieve. Remember, we talked about that CC0 and CC1, because that's where the maximum benefit of the operation lies. If we can't provide you a full, complete operation, we are really committing you to not having the best possible outcome. So how do we assess that? CT, MRI, you've heard me say this a few times, but they're not foolproof tests. And the true test of whether we can really do something is when we actually go into the operating room. And so there's a lot of planning that goes in. For some of you that have already been through this, you've been through it. And a lot of people ask, I'm healthy, I'm great. Why do I need to see everybody? But there's a reason we have you see everybody, because we cannot do this by ourselves. It's a difficult operation. We need all the help we can for our patients to get them safely through. A huge role for what nutrition does in patients before surgery and after surgery. And so we always have you see a dietitian. Huge role for your physical stamina and endurance, and how that it plays with your overall outcome from the operation. And that's why we have physical therapists see you routinely. There's a full multidisciplinary team that assesses you for that reason. We want to minimize complications, maximize benefits. That's the goal. Average patient spends about 8 to 10 days in the hospital. Our data usually between 7 to 8 days for our outcomes. When we used to do these procedures back in the early 90s, mid 90s, patients were spending 30 days in the hospital, 40 days in the hospital. I mean, techniques of anesthesia have improved. We've started selecting our patients, not to be selective, but to really give the benefit of the operation to the candidates that really will benefit from surgery. And so we've really improved our outcomes over time. We have protocols, algorithms for how to standardize management of patients after surgery. And some of you who've been through this procedure at our institution know we have a team that rounds, we have an organized way we do things throughout the operative course, post-operative course. And then long-term follow-up is super important, because obviously we want to try and detect recurrence that does happen anytime soon. Side effects, plenty. I've only listed a few, but commonly, these are some of the side effects. The biggest ones, I would say, for patients that sort of linger over time, not necessarily the acute ones, but is the difficulty in being able to eat, or drink and keep up their nutrition. And Kerry will talk to us a little bit about that later. Physical energy and stamina can be a huge issue. A lot of you will tell me that it's really hard to get tasks done without feeling wiped out and having to go take a nap, right? And I encourage everybody, take naps, but get up and move around, right? So these are challenging issues. And, I've never been through this procedure myself, but I've seen a lot of this happen with our patients, and you don't understand how challenging the recovery is until you've been through it yourself, or you've seen your loved one or your family member or partner or whoever it is go through it. So difficult problem, and it takes a village to help people through this. Briefly, because I don't want to take too much time, but we can go over some of the cancers. So appendix cancer basically is what we call mucinous and non-mucinous cancers. The mucinous cancers are called pseudomyxoma peritonei. And basically it means tumor spreading outside the appendix into the rest of the abdomen. This is a representative picture of a patient with high volume tumor. We usually grade these as low and high grade tumors, and the high grade have high grade without and with signet ring cells. Generally speaking, the higher the grade, the worse the outcome. This is that survival curve we talked about earlier, but what really determines prognosis in the long term is the subtype, so low or high grade, how much was the disease or the PCI burden, and then the CC score. And you can see from the table below that patients who have the low grade disease, 90% of them will still be alive, at 3 years, and 85% will still be alive at 5 years. Not so much, unfortunately, for the high grade, especially those with signet ring cells. And there's no designated threshold at which point we say, sorry, we can't offer you an operation. Again, highly individualized decision, but by and large in patients with lower grade tumors, we can accept a little bit of a higher PCI score before we say you are not an operative candidate. The high grade tumors, unfortunately, by nature of how aggressive they are, we want to see much lower volume of disease. Some of the tumors can be very, very difficult to manage, especially those around all the bowel segments or causing multiple obstructions, or in what we call the porta hepatis. If they're caking those areas, unfortunately, many a times we can't do a whole lot surgically. And so we try our best, but if the tumor is beyond those areas, sometimes we have to, unfortunately, find other ways to treat rather than HIPEC. Colon cancer, this is, been a challenging issue to deal with peritoneal metastases for a really long time, but by and large, the data has been through multiple what we call retrospective studies and some randomized trials, but it showed very early on that in comparison to just chemotherapy, surgery and chemotherapy has a much better overall long-term effect or outcome. This is both in the era of chemotherapy before we had drugs like oxaliplatin and irinotecan, as well as after. And then for folks of you that have colon cancer, the big question now in today's day and age is whether the HIPEC portion of the operation really helps, or is it just the cytoreduction? And this is a question that has been somewhat answered in Europe, but with some caveats where they basically flipped a coin and put patients either in the HIPEC group or just the cytoreduction group alone. And what they found is that the survival curves were pretty similar. So in both groups, patients lived on an average to about 42 months, and the recurrence rates were not dissimilar either. But there was a subset of patients with these intermediate burden of tumor that did benefit from HIPEC. So it brought up a lot of questions and a lot of criticisms, especially those in North America, because we still tend to believe in the role of HIPEC. And that's because when they designed the trial, there were some flaws with how they selected the total number of patients they included. They used oxaliplatin for a really high dose and a really short duration, just about a half hour, which really didn't give much time for the chemo to act in the abdomen. So that was a big criticism. They also used oxaliplatin in patients who had already been exposed to oxaliplatin IV. And so arguably the tumor cells left behind were all resistant to oxaliplatin. And so we don't use oxaliplatin for that reason. We use mitomycin. And then they had a lot of crossovers of patients. So needless to say, there have been a lot of criticisms of this trial, and we haven't really used it as gospel, and we still offer HIPEC to colon cancer patient on an individualized basis. So in summary, there's a definitive role for HIPEC as long as we treat them in high volume centers that have experience and hopefully get patients in the door as soon or early as possible. Very good long-term outcomes in when selected patients. And it's really important to understand the disease process, the technique, the biology of these tumors to really maximize the benefit of treatment. Thank you. Yes.
Oh.
So the way we assess PCI is when there are different ways to assess PCI and CC scores. So the gold standard by which we compare always is intraoperative assessment at the time of surgery. So when we open you up, we literally inspect every single quadrant, and you get this by experience, and we measure the size of the nodules. If the quadrant is completely covered in tumor, then that's automatically a PCI of 3. So that's how we measure it. And then the CC score we assess based on what we leave behind. And in many patients, we can get a CC0, but in many patients with high volume disease, we aim for at least a CC1 because it's almost always impossible to get rid of all the tumor along the small bowel.
I don't know. Oh, it is working.
Yeah.
If you had laparoscopy,
Correct.
Do you have a CC?
Yes. So if you have so that's an excellent question. So I didn't go into details, but in some patients in whom we are concerned that we may not be able to do a complete cytoreduction or get a CC0 or a CC1, we will do laparoscopy prior to the cytoreduction. And the laparoscopy is another way to look directly inside the abdomen. But again, laparoscopy has its limitations. One is, so it'll give us a PCI score. You're absolutely right, because we'll be able to see many quadrants. We'll be able to see some parts of the bowel, et cetera. But the limitations of laparoscopy extend to the point where we can't thoroughly explore every single nook and cranny of the abdomen like we can do with an open operation. Secondly, we can't feel with laparoscopy for tumor nodules. Thirdly, and very importantly, most patients that come to us after for cytoreduction and HIPEC almost always come to us having had a prior surgery. So say they had their appendix out, tumor was noticed, mucin was noticed everywhere, and now they're coming to us. Or they went to their gynecologist because they had an ovarian tumor. They had a workup. The working diagnosis was an ovarian cancer, but then when they went in, they found out, oh, wow, it's actually an appendix cancer. And then they got the ovaries and the appendix out. So whenever we have prior surgeries, we have scar tissue formed. And then when you have scar tissue, it's really challenging to assess laparoscopically. So while laparoscopy overall can correlate well, it's not 100%. Now, what laparoscopy can do is it can tell us fairly quickly if someone is not a candidate for surgery. Because if we go in with a small, camera and we notice that the bowel has tumor everywhere, then we know that surgery is not going to be much of much benefit. So I use laparoscopy more in the context of, ruling out somebody rather than ruling in somebody, because if I know somebody's going to be a candidate or I have to give it an honest chance, laparoscopy is not going to be giving me a full idea. But if I put in a scope and I see way too much tumor, then I can rule someone out relatively quickly. The CC are you talking about the CC score, or you mean after surgery? So there's no good way to do that. There are assessments that we call CT PCI scores or MRI PCI scores, but again, they somewhat correlate with the actual PCI score you see in the abdomen, but they're not foolproof because unfortunately imaging underestimates tumor burden many a times. So we have patients where there are 2 or 3 nodules noted on scan, but when we open them up, there are way more smaller tumors. And so unfortunately, CT and MRI don't give a very good evaluation of a PCI score in the future. And if you've had a cytoreduction before, then doing laparoscopy is very challenging, especially if you've had a bunch of the peritoneum stripped because the scar tissue can be prohibitive. Okay. All right. With that, we can go on to our next speaker. So it's my pleasure to introduce Dr. Cohen. Many of you already know Dr. Cohen. She's an associate professor of medical oncology at Fred Hutch Cancer Center and UW Medicine. She co-leads the HIPEC Multi-D Clinic, a prolific clinician and researcher, and a mentor to a lot of trainees and junior faculties. And while we're bummed she can't attend in person, we are thrilled that she's still able to give us her talk today. So Dr. Cohen, take it away.
Hi, everybody. Virtually, it's a pleasure to get to be with you all. And again, as Dr. Mogal said, I'm very sorry not to be there in person, but happy still to get to participate. Hopefully my coworkers in the form of dog and small children will leave us alone for the duration of this time. So my talk here is about the medical oncology side. So thinking about chemotherapy and medicines and how those can be used to positively influence a patient with peritoneal disease. And so when we think about that, we're using some different therapies, and we have both local therapy and systemic therapy. And I see someone at the podium. Can you all hear me okay? Richard, can you hear me okay? Can you wave or give me a thumbs up? Okay, great. So local therapy is a treatment delivered just to one area, like to the liver, or in this case, the region of the body, which is the peritoneum. And we're really only treating that area. Whereas systemic therapy, which is what I'm typically giving, is a treatment often intravenous, given with the intention of going through the blood to the entire body. So, one is more targeted, one is system-wide. When we're doing a local therapy, we're really using this for a limited area, maybe curative intent of that area, or maybe palliation, meaning we're just addressing symptoms, such as a lot of pain that one tumor may be causing. And the side effects are typically regional to that area of the treatment because it's only treating that area and then missing any cancer outside that targeted area. When you have a system-wide treatment, we're using it to shrink the cancer burden overall, or maybe to control the cancer in the form of metastatic disease, or potentially postoperatively to reduce the risk of recurrence. But the problem with system-wide therapy or systemic therapy is that the side effects may be more global, may have nothing to do where the cancer actually was located, but it can work on both visible cancer that we can see on scans as well as microscopic disease. So just highlighting those things with systemic therapy. So again, we're trying to, in this case, in the case of peritoneal disease, shrink the cancer burden, reduce the risk of recurrence, and again, influence micrometastatic disease. So for those of you who have a GI cancer, you may already know this, but just as some background in terms of the drugs that we use, our main drug that we're using is 5-FU or 5-fluorouracil, or its oral prodrug called capecitabine, with the trade name being Xeloda. We can combine that with oxaliplatin and we make FOLFOX. We can combine that with irinotecan and we make FOLFIRI as the combination name. Sometimes we'll do all three, and that's either referred to as FOLFOXIRI or FOLFIRINOX, depending on the dosing. If we can't use 5-FU, we may use IROX. We can add bevacizumab, trade name is Avastin, or there's biosimilars for that. And then we could add EGFR inhibitors called panitumumab, which is Vectibix, or cetuximab, which is Erbitux. And so we can increase the efficacy of the regimen by adding multiple drugs together, though we know not to add both the biologics, as that has been harmful. And then following progression on these, and we also have regorafenib and then trifluridine tipiracil in combination with bevacizumab. So the reason why this matters is because, as we've seen over time, and this is data from colorectal cancer, but that as we've had more drugs, we've seen improvements in outcomes. So if we take that, the higher that blue line, the better, because those are patients that are surviving and how long they're surviving. As we've looked over the decades, we've seen that as we've had more and more drugs approved for metastatic colorectal cancer, we've seen an improvement in overall survival. And of course, this is not only related to drug therapy, it's also going to be related to better surgical techniques and imaging and everything, but at least we're going to take a little bit of credit of that in medical oncology. So as Dr. Mogal said, we know from some large databases that patients who have cancer that has spread to the peritoneum has a worse prognosis, and that's compared to other sites of metastasis. When you look at these survival curves, everyone's starting at the top at 100% alive, and then as the lines fall down, that means patients have passed away. And so we hope that the lines stay as high as possible, but what we see is that with peritoneal metastasis, which is isolated, so only in the peritoneum, that's the purple line in the middle, those patients do better than patients who have peritoneal metastasis and other organs such as the liver. And so we're thinking about that as we approach an individual patient, just recognizing that the more advanced the cancer, the more likely we are to see a recurrence. So for peritoneal disease, we could just use chemotherapy systemically. We are never required to do a HIPEC procedure. Of course, that's the purpose of today's talk, but we also need to give some caveats that surgery is not for everyone. And it can be, as you just heard, a very invasive procedure with a prolonged recovery. So we really want to have a good conversation with patients to make sure that that's something that they want to do. And so, of course, though, if that is the goal, we're trying to do an aggressive type treatment, we also want to do an aggressive type chemotherapy regimen to try to maximize those responses. So again, we're trying to decrease the amount of cancer that's in the body. We want to shrink or control tumors that are even too small to see on imaging. And we know that even with our best PET scans or CT scans or whatever scans that are done, we can underestimate peritoneal disease. It just can be too small to see by imaging. And then we also want to get rid of micrometastatic disease. So as much as I trust Dr. Mogal and Dr. Sharib and surgeons of this caliber, unfortunately, they cannot see everything, and there could be microscopic amounts of cancer that's too small to see. So the goal would be to kill that off with chemotherapy as well, and so that you don't have a recurrence after surgery. So what do we actually do? If you have metastatic colorectal cancer, and we can extrapolate this to appendix cancer and use similar paradigms for other sites, we tend to just use 5-FU-based therapies over and over until we end up with not being able to do that. And then we start thinking about, okay, we need to move on to other types of drug therapy. If we have someone that is desiring a more aggressive approach, then we're going to say, what if this person could have surgery? Could they have cytoreductive surgery and HIPEC? And so in that case, we're giving as aggressive as possible chemotherapy. When we give it before surgery, we'll say it's neoadjuvant, and we give that for 4 to 6 months. And along the way, we're doing scans every 3 or 2 months to make sure that the cancer is not worsening. And I say it like that because, again, we might not see how much cancer is there. So we really want to see that it shrinks, of course. But even if we just see it stable and Dr. Mogal or Dr. Sharib thinks, yes, I could take this out surgically, then we would still proceed with surgery. But to double check that, we'll do a diagnostic laparoscopy at 5 months. And so the idea is that you do it a little bit before the end of the chemotherapy and just do a look to say, does this make sense? We've had the majority of the response that we're going to see from the chemotherapy. So let's pause and get an actual assessment of the cancer disease burden with that PCI score and get an assessment of if it makes sense. And if it does, we'll finish out the chemotherapy, maybe do that final scan, and then proceed with surgery. But this is where it's really key to be at a center that has frequent multidisciplinary review, because as we gently hand off between surgery and medical oncology, we want to make sure that we're always keeping everything holistically in mind in terms of what a patient wants, what a provider thinks is possible, and sort of trying to optimize everything along the way. So, you may ask, well, what is the data for this? And unfortunately, we don't have a lot of data, but this is one study that was done called the Cairo 6 trial. And it actually randomized patients to getting chemotherapy before and after surgery with CRS HIPEC, or they just did the surgery. And so it was a very small study because you can imagine it's very hard to enroll to these types of trials. Not a lot of people are willing to be randomized and not have the option of whether or not they get chemotherapy. But when we look at this, if you look at the patients that had treatment prior to surgery, so everyone in that arm started chemotherapy as planned, and about 1/3 of patients actually had shrinkage of the tumor. So most of them just had stable disease, and we didn't actually see any change. So we don't expect huge shrinkage, but of course we like it when it happens. And then 89% were able to undergo the HIPEC and CRS procedure. And then afterwards, though, because patients are often frail and are recovering, or maybe having prolonged surgical issues, only 1/3 of patients were able to get all of the planned chemotherapy for afterwards. On the other hand, of the 42 patients who were planned to go for surgery, only 36 of them, or 86%, actually had the complete CRS HIPEC procedure. So sometimes, again, if you go in, open the abdomen, sometimes you realize it's not the situation that you thought, and not everybody was able to go through the procedure. So what we took away from this is that when you looked at the use of chemotherapy before and after, the complication rates were pretty similar. But it seemed like the best thing to do was to give the chemotherapy before surgery, because a lot of people were not able to get it afterwards. So when you're in clinic with me or with our team, we're going to be trying to maximize that 6 months of chemotherapy prior to surgery if someone can tolerate it, because we think that that is the way that we're going to get the best outcomes. But of course, we still could give chemotherapy after if it made sense. And some folks in the chat have asked about targeted therapy. So if there is a really good target, then we think that that should be used. But these are rare targets. So we could look for BRAF mutations, HER2, MSI or ultra-hypermutated tumors. KRAS G12C is a new target, and then NTRK and ALK are pretty rare. But these are all targets that we now have somewhat reasonable targeted therapies. And so if you're thinking about having a very big surgery, we often want to consider these options. Some are available as standard of care, and some of them are only available in a trial. But we really want to think, does it make sense to just go right to surgery after chemotherapy? Or perhaps should we be exposing somebody to one of these treatments that may be much more effective? And so it's part of the consideration for every patient. I do want to mention, this is a little bit older now, but I had a lot of questions about dostarlimab after there was a big study released a year ago, at least the initial data. It was written up in the New York Times. It was well published and reporting a 100% complete response rate. The problem is that this was just done for localized rectal cancer. We know that this drug class exists. That's what I mean by PD-1 inhibitors or immunotherapy. So please rest assured that we are screening every patient for the use of immunotherapy, but we do not expect these landmark responses in 100% of patients outside of very localized tumors. So what do we do afterwards? You're going to be seeing your team for 5 years minimum. And so we're thinking about what kind of symptoms is someone reporting. So some of them may be very expected, like pain after surgery, but we're really paying close attention to those abdominal or digestive symptoms to see if they suggest that there could be a persistent cancer or recurrent cancer. We would be doing blood tests, including tumor markers like CEA, CA19-9, CA125. You'll be getting endoscopy or colonoscopy for screening of the bowel, and then also getting CT scans. It's uncommon that we'll use a PET or MRI just because those are less helpful in these situations, but certainly those are used rarely. And the one tumor marker I didn't put on here, but that I do a lot of research in, is circulating tumor DNA or ctDNA, and I'm certainly checking that on my patients as well. So even with all of these opportunities, recurrences can still be hard to detect because peritoneal disease can be just relatively hard to see. But that's why being at an expert center, hopefully we are more equipped to be able to help you. So just some basics about what are we doing with our tumor markers. So in basic biology, we've got DNA, which you can get to RNA and then translate it to proteins. You can think about how single cells grow up into tumors. And as we try and sample that, our classic way had been with a tissue biopsy of actually putting a needle in, whether surgically or through the skin, and taking a sample of the tumor to try to look at the genetic mutations. Now we also have blood-based markers, which include proteins like CEA that the tumor can make, or the so-called liquid biopsy, where we're taking a sample of DNA that's fragments of DNA that are floating in the bloodstream and looking at tumor mutations or just even the presence of tumor, and that's called ctDNA or circulating tumor DNA. So what is ctDNA? It's something that we all have cell-free DNA in our bodies. As cells break down, they release the DNA. It only lasts for a few hours in the body. But what we're looking for here is that specific mutations to the tumor. So this has been a technology that's been around for a very long time. Some women may remember getting prenatal aneuploidy screening, so getting a cell-free DNA test while they're pregnant to look for potential fetal alterations like trisomy 21. And so they took the same concept of this and then said, okay, instead of looking for fetal DNA, we're looking for tumor mutations, and that's what ctDNA is. And the nice thing is it turns over really quickly. It only lasts a couple hours. And so you're getting a really, hopefully, accurate sample of what's going on at that moment. The more cancer you have, the higher the level may be, or easier for it is to detect. And then we also know that there's some false positives. So with every technology, of course, it's got its limitations. And the idea that we can use it here, for example, after surgery, is looking for what we call MRD, which is molecular residual disease, also called minimal residual disease. And so this is this idea that you could pick up on something that you can't find by scans, you can't find by CEA, but that you're actually finding these fragments of DNA. And so the hope is that we're actually able to pick up recurrences faster. To date, our analyses have largely been retrospective or observational, but we do have some emerging prospective data. So the idea here is if we took that same curve, and this is an imagination, but if we took that same curve where 100% of people were alive, and in the middle you have all patients in the black line, the idea is that if we did not detect ctDNA, if they were negative, you would actually be picking out the group that did much better. That's the blue line, ctDNA negative. Whereas patients who are ctDNA positive are still having active shed into the bloodstream. And so those patients have active cancer somewhere. We expect them to have a higher recurrence rate, really near 100%. So the hope is that you could use ctDNA to help parse out who is likely to recur and who isn't. So as an example of some of the data that's been reported, this is the Galaxy study. This is over 1,000 patients who had colorectal cancer, and they got serial ctDNA testing for 2 years after surgery, and 18% of them turned positive. And so if you look at that curve on the right, which is disease-free survival, you do actually see the curve separate kind of like the cartoon, where the patients who are negative really rarely recurred, maybe only 5% of the time, whereas patients who are positive had a much higher recurrence rate. And if we think, well, why are they not all recurring? It could be because some of these patients had chemotherapy after surgery, and hopefully that was beneficial. On the right, we have an example of how you see it dynamically. So the best outcomes were patients who were negative the whole time. They never had detectable ctDNA. But in the light blue, you have patients who are positive and then they converted to negative, probably after chemotherapy. They did really well as well. Whereas patients who were always positive or turned positive, they had really high recurrence rates. So we think of this as both a single time point and a dynamic test that could be done. We've also shown this in a real world experience. This is some real world data that I participated in, noting that we see high levels of ctDNA pre-surgery on the limited patients that are detected, but that we also see it about 50% of time in the long term. That's what the surveillance line means. 46%, or about half of patients, had detectable ctDNA, and which is what we expect for recurrence rates. And that when you look at the quantitative values, you expect it to be higher for patients who recur. And then there's similar data that's been reported, a bigger study of colorectal cancer patients. And again, looking at one time point or multiple time points, again, just looking at the way that those curves separate, the longer someone stays negative, the more reassuring it is, especially in patients who are stage 4, who we think of as having a higher likelihood of recurring. So what do we do in clinic? When I'm sitting down with a patient, I'm thinking about, what's the goal of therapy? Does someone want to think more about quality of life? Are they saying, get rid of this cancer at all costs? What are we thinking about? What types of treatment has the person already had? So where is there room to add? What other medical issues does the person have that might impact their ability to get treatment? What is the tumor molecular testing? What is that genetic profile? And are there any unique targeted therapies? Maybe we could add or remove drugs to try to prepare the person for surgery. I try to be aggressive, but actually sometimes too much chemotherapy can be a bad thing because you make someone very sick and they don't tolerate surgery very well. So that's sort of a dynamic question. And then the last question, which of course is done in conjunction with my surgical colleagues, but does an attempt at surgery make sense? Because sometimes we think, well, look, we've maximized the benefit we can get from our chemotherapy. And so let's move on and let's think about if surgery is the right next thing. Okay, the rest of these slides we're going to save for later and Dr. Sharib is going to present, but thank you all for listening, and I'll look out to the chat for some questions.
Well, let me pull up the chat real quick. I don't see any actually, any specific questions for Dr. Cohen here. Any questions from the audience that we can relay? I think she should be able to hear us. No. All right. Oh, actually, yeah.
The ctDNA test, was that specific to one type of cancer that I mentioned, or is that for any peritoneal type of metastatic tumor?
Are you able to hear that?
Yeah, so it's a good question. Question is whether ctDNA is specific to a tumor type. So the majority of the data has been in colorectal cancer, and depending on which platform you use, of the two commercially available platforms, one is only permitted to be used in colorectal cancer, and one can be used for any cancer type. There's a lot of differences. I mean, I could talk for a long time about ctDNA, but the one that is tumor informed is agnostic of tumor type. You could really use it for any type of cancer. The one that is tumor naive that just requires just a blood sample. That one is only permitted for use in colorectal cancer right now, but of course this is an ever-changing field, and so we expect it to really evolve over the next several years.
Thank you. All right. Well, our next speaker today, I'm very pleased to welcome Dr. Barbara Goff. She's a Fred Hutch physician and affiliate investigator. She's also a professor of gynecologic oncology at the University of Washington and the chair of the Department of Obstetrics and Gynecology at UW. She's also the surgeon-in-chief of UW Medical Center, and similarly has been a mentor to countless residents and fellows over the years, including some that I've met even at private institutions. So welcome, Dr. Goff.
Great. And then I can just use these to move forward. Okay, great. All right, well, we're going to switch gears a little bit and we're going to talk about ovarian cancer and the use of HIPEC. Great, thanks. And the use of HIPEC for this patient population. Maybe not.
Just click here.
Okay, great. So intraperitoneal chemotherapy has actually been used for quite a long time in ovarian cancer. It was probably one of the first diseases where we really utilize this idea of dose intensity in the abdominal cavity, because ovarian cancer tends to be confined to the abdominal cavity, very similar to pseudomyxoma peritonei or appendiceal cancer. And in 2006, the National Cancer Institute actually issued a clinical alert, which they rarely do. And they strongly urged the use of intravenous and intraperitoneal chemotherapy following surgery for women with ovarian cancer, because back in 2006, they saw through multiple studies that survival was extended by over a year in ovarian cancer, which was really quite a significant improvement in overall survival. And one of the sentinel studies that really resulted in this NCI clinical alert was a study in which patients with stage 3 disease, which would be disease that had spread to the peritoneal cavity, but not outside the peritoneal cavity. And when surgery was successful in removing almost all, or either all or almost all of the cancer, survival was much better with 6 treatments of intravenous and intraperitoneal chemotherapy than just 6 treatments of IV chemotherapy alone. So I think that this, knowing that IP chemotherapy makes a big difference in ovarian cancer, this is what sort of raised interest in using HIPEC in this group of patients. So for at least a decade, intraperitoneal chemotherapy was really considered the standard of care for women with intraperitoneal ovarian cancer, but it came at a rate of quite a bit higher toxicity. There was a lot more abdominal pain, nausea, neuropathy, which means you get numbness and tingling in your hands and feet, lowering of blood counts, and then there were catheter complications from, sometimes people would get bowel obstructions or other problems from the catheters that were left in for 6 months to a year after the surgery. And then with new drug combinations, particularly our targeted drugs, we basically saw the survival advantage from intraperitoneal chemotherapy really sort of disappear. And the other thing that has really changed in ovarian cancer is over the last 5 years, we've really come to understand the importance of maintenance chemotherapy, where after people get their surgery and their chemotherapy, almost all patients with advanced ovarian cancer now are treated with 1 to 3 years of maintenance chemotherapy. And we'll talk a little bit more about that at the end, and how do we determine what kind of maintenance therapy people should have. And I should say that maintenance chemotherapy is important whether you have HIPEC or not. And as I said, this has been a change in the landscape of how we treat ovarian cancer. So in ovarian cancer, HIPEC has been used in a number of different types of scenarios, and there have honestly been mixed results, similar to what Dr. Mogal was saying earlier. So HIPEC has been used when people get surgery up front, and then they get HIPEC and additional chemotherapy. It's been used in the setting of neoadjuvant chemotherapy, where women who have a little bit more poor prognosis actually get chemotherapy up front. Then they get surgery, get HIPEC and additional chemotherapy, or in people with favorable recurrent disease, they'll get surgery, HIPEC, and then additional chemotherapy. And in all of the studies that have been done looking at this, patients have surgery, and then at the time of surgery, there's a coin toss, and they're randomized either to HIPEC followed by traditional chemotherapy, or just traditional chemotherapy, which would be intravenous chemotherapy, typically with Taxol and carboplatin. So with HIPEC in ovarian cancer, we typically use either cisplatin or carboplatin. It's heated to 40 to 43 degrees, and there's a 90-minute run of the infusion pump to bathe the abdominal contents with this heated chemotherapy. It should only be performed if the surgery is successful, just as Dr. Mogal was saying, and there's really no role for interperitoneal or HIPEC if the disease cannot be optimally resected. It basically, it doesn't add anything to survival if you can't get all the disease out. So looking at HIPEC after upfront primary surgery, and so this would be patients get surgery, they flip that coin, you either get HIPEC or nothing, and then you get more chemotherapy. Actually, studies have shown that HIPEC is not all that advantageous in terms of survival advantage. So on this survival curve here, you can see the control group, which is a group that didn't get HIPEC versus HIPEC. Statistically, there was no difference in overall survival, but you can see it looks like the control group maybe even did a little bit better than the HIPEC group. And there was another study published last year from Korea in which those who received HIPEC had a progression-free survival of 29 months compared to 24 months in the group with HIPEC. And when they looked at overall survival in the control group, the median survival had not been reached, where it was 73 months in the HIPEC group. So again, no improvement in overall survival for HIPEC in this group. Now, in the neoadjuvant chemotherapy group, we see a different story. And there have been 2 studies, both have used heated cisplatin. And again, this is when you get 3 cycles of chemotherapy, you then go to surgery, we do the coin flip again, and then you get an additional 3 cycles of chemotherapy after the surgery. And in these 2 studies, we see that surgery plus HIPEC results in a significant improvement in overall survival. And in fact, this study was just represented at the American Society of Clinical Oncology just last weekend. And they did a 10-year follow-up from this study and showed that the survival advantage of HIPEC persisted in this European population compared to surgery alone. And then another study from Korea found very similar findings where we saw that the surgery plus HIPEC was significantly better in terms of overall survival compared to the control group, which did not get HIPEC. Another study from looking at in the recurrent setting, this is a study from Memorial Sloan Kettering that was published in 2021. And this was patients who had favorable recurrence, meaning that they had gone more than a year from completing their chemotherapy. And what they found in this study was that the use of HIPEC, and in this situation, they used the drug carboplatin, that there was no survival advantage to using HIPEC in the platinum sensitive recurrent situation. So you can see it is kind of a mixed result in terms of when we should use when we should consider HIPEC, and the strongest evidence is in the group who gets chemotherapy, then gets surgery, and then gets additional chemotherapy. And in preparing for this lecture today, I just did a quick scan of, is there anything interesting that was published on HIPEC and ovarian cancer? And I came across this really interesting case report from MD Anderson, in which they had 2 patients, one with advanced and one with recurrent primary mucinous cancer. And in general, mucinous tumors of the ovary, they're very, very chemo resistant. They don't really respond to any of our usual chemotherapy drugs for ovarian cancer. They don't really respond very well to the colorectal drugs. And so we're often at a loss as to what to do with these patients. But these were 2 cases in which they did cytoreductive surgery. These patients were optimally cytoreduced to an R0 resection. They then received 1 dose of HIPEC at the time of surgery, and they received no additional chemotherapy. And both were alive without evidence of disease at 21 and 27 months. So I really think this is a protocol that we may want to think about adopting here, and not bothering with the additional chemotherapy for these patients. Side effects from HIPEC are similar to other cancers. Mortality does not appear to be increased with the use of HIPEC. 25 to 30% of patients will have serious surgical complications, but it's not significantly higher than surgery without HIPEC. Kidney damage from the cisplatin is often reported, but it's preventable with pre-medication. And again, it's one of the reasons you want to be treated in a center where people do this a lot, because what we want to do is prevent complications. And that's why the prehabilitation before surgery, the nutrition consults, the multidisciplinary team is so critical to having good outcomes. Average length of stay for patients with ovarian cancer is 8 to 10 days, exactly what Dr. Mogal said. And long-term quality of life, which is important, does not appear to be worse in those patients who receive HIPEC. So just wanted to talk a moment about maintenance treatment. As I said, the landscape for treatment of ovarian cancer has really changed over the last 5 years. Maintenance treatment is guided by the results of germline testing, which means that do you personally have a mutation, and somatic testing, which is does your tumor have a mutation? And those are two different things. And we use both of those to determine what sort of maintenance therapy you should be getting. So people who have germline mutations, meaning you personally have a mutation in one of the BRCA, the breast and ovarian cancer genes, you should receive 2 years of PARP inhibition treatment following your initial surgery and chemotherapy. And studies have shown that there is a 70% reduction in death for this group of patients who have these germline mutations who go on to take PARP inhibition. Patients whose tumors have a homologous recombinant deficiency should also receive 2 years of PARP inhibition, because they have about a 40% reduction in death if they receive 2 years of PARP inhibition. And then for those without a germline mutation, or those whose tumors don't have homologous recombinant deficiency, typically these patients will get 1 to 2 years of bevacizumab, trade name Avastin, following their initial treatment. So that kind of summarizes what we're doing in the ovarian cancer space. I think, again, in conclusion, it's not for everyone with ovarian cancer. It's for a specific subset of patients with ovarian cancer, and all of the same criteria that Dr. Mogal mentioned about, being healthy enough or being fit enough, and the importance of a multidisciplinary team all apply in ovarian cancer as well. So that concludes what I have to say. If there's any questions, I'm more than happy to answer them.
Okay, moving along. It's my pleasure to introduce one of the newest members of our HIPEC team and family, Dr. Jeremy Sharib. Dr. Sharib completed his residency at UCSF, where he did 2 years of research in the lab, and then did a combined fellowship in complex abdominal oncology and hepatobiliary surgery at Duke University. And we were fortunate enough to recruit him thereafter to be part of our HIPEC program. Today he will be talking to a little bit about HIPEC and mesothelioma.
Thank you. And I know we're running a little bit behind, so hopefully I can catch up some of that time here. But yes, thank you for the introduction. My name is Jeremy Sharib. It's my first high five for HIPEC, but I'm excited to be here and speak to you a little bit about mesothelioma today. There we go. So malignant peritoneal mesothelioma is a rare cancer. It's a little bit different than some of the other diseases that we've been speaking about today that are actually arising in other organs and spreading to the peritoneum. Mesothelioma actually arises from the cells that line the peritoneal cavity. It can arise in other cavities as well. You may have heard it in the chest and other areas where their mesothelial lining exists, but today we'll specifically talk about peritoneal disease. It is a rare cancer. Overall, there's about 3,500 cases of mesothelioma in total across the United States per year. And peritoneal mesothelioma makes up only about 15% of these cases, so only about 300 to 400 cases per year. So again, very, very rare. There is a little bit of a higher incidence in men across all types, and that includes peritoneal mesothelioma. However, in women with the disease, the more likely location of disease is actually in the peritoneum, so maybe an important group there. Asbestos exposure is part of the disease, regardless of where it occurs. However, unlike the lungs, where pleural mesothelioma occurs in the peritoneum, the asbestos exposure is thought to be through the bloodstream, so mechanistically it may be a little bit different. And because of this association, actually the decreased use of asbestos over time with industrial uses, actually the incidence may end up decreasing over time. There are also some mutations associated with this disease in both de novo and familial cases, which include the BRCA1 associated protein BAP1 or ALK mutations or fusions. Though these are rare, it just gives an importance to getting a history of cancers that are associated with these mutations, like melanoma, uveal melanoma, renal cell carcinoma. How do these present? Very similarly to peritoneal disease and other cancers that we've been speaking about today, but maybe more specifically to peritoneal mesothelioma, a lot of patients will present with ascites, a number with abdominal pain, distension or bloating, or perhaps bowel obstruction. These issues are also associated with a lot of secondary kind of symptoms, which may include changes in appetite, nausea, vomiting, difficulty breathing, fatigue, and these are all pretty non-specific symptoms, as you can imagine. And so often the diagnosis will be pretty delayed and maybe later in the course. When we have a presumed or concerning diagnosis, the way that we really bring this to establishing a diagnosis of peritoneal mesothelioma is through a history and physical. Again, with special attention to asbestos exposure, other occupational exposures, history of cancers, smoking. For us, knowing abdominal surgeries, as well as kind of overall fitness and thinking about what the next steps of therapy will be is really important. Patients within that workup will get a CT of the chest and then a CT or MRI of the abdomen and pelvis. That is going to be part of the workup. There's no specific findings necessarily for peritoneal mesothelioma, but we can get an idea of the extent of disease based on these imaging studies. And then similarly, PET scan may be used, although not for everybody right at the beginning of the disease process. It could be part of at some point. There are tumor markers, including CA-125, that can give kind of an idea of how extensive or aggressive the disease may be. But in general, if we do see nodules or anything that's of concern, a biopsy is required for diagnosis. And this should be a true core biopsy, not an FNA, because we need to be able to differentiate type, which, as you'll see in a couple slides, is very important. We've spoken a little bit about laparoscopy, and for peritoneal disease, we use this fairly readily. I generally describe it as allowing us to get a good map of the patient, given patient's disease, and know the extent within the peritoneal cavity using that PCI index that Dr. Mogal had spoken about earlier today. Again, it does have some limitations, but it gives a good idea of what sort of expectations we can have for a successful surgery, which we'll speak about in the next few slides. And then finally, just a reminder for all the patients and all the diseases that we're discussing today, the data that we get from our diagnostic studies, we bring together and present in a multidisciplinary conference, which includes surgical oncology, medical oncology, radiology, and pathology, to be able to talk about all the nuances of these diseases and really make a personalized plan for each person. So that's critically important to this particular disease. So in terms of treatment, I put up this slide because actually just in 2021, the NCCN made their first guidelines for peritoneal mesothelioma, which were really, I think in our kind of view, was in some ways created as a complement to what was called, or what is called, the Chicago Consensus, which is a surgical consensus guideline that was published first in 2018. And it's kind of a really exciting news for peritoneal mesothelioma because it's really difficult to get national guidelines to both include and accept cytoreduction and HIPEC within the actual recommended treatments, because it's really hard to provide large scale studies of these diseases and therapies since they're so rare. And so it's really a testament to the efficacy and kind of the outcomes for cytoreduction and HIPEC that have been shown in larger retrospective studies or smaller kind of single institution, single arm studies for mesothelioma. So again, when I kind of alluded to it, but the very first thing when we establish a diagnosis is to think about type. And so the first thing I'll mention is just a couple of these entities that we consider kind of more in the I guess akin to the low grade for appendix or colon. And these are both fairly rare. And they actually are not totally clear if these are cancers in and of themselves or they represent really progressive disease. So given that they're not always clearly malignant, they're neoplastic, these will often be surveilled. And if there's no progression or no symptoms, that may be the only treatment. However, there's always a possibility if progression or symptoms do arise, these are treated primarily with cytoreduction and HIPEC. In the more aggressive forms, which we kind of broadly use the term diffuse peritoneal mesothelioma, further staging is necessary, and that's similar to any of our other diseases, except that peritoneal mesothelioma differs from some of the other solid tumors in that the typical TNM staging applies a little bit less so. They're mostly staged by the extent of disease, and in practice, the extent via either PCI or nodal or extra abdominal staging is actually kind of what impacts the treatment and prognosis for these. So generally, if we think about it, patients with stage 1 or 2, so really disease that's more limited to either one or kind of limited multi-quadrants of the abdomen are more likely to be offered cytoreduction and HIPEC because of the possibility to achieve an optimal response there versus people who have maybe higher stage disease in the nodes or extra abdominal sites. Again, regardless of stage, one of the first branch points is the type. And so first I'll just talk about the most common type, which is the epithelioid histology. Patients who do have epithelioid type who do not have significant comorbidities and most importantly we can achieve a complete cytoreduction. Cytoreductive surgery and HIPEC may be considered as the first treatment with adjuvant systemic therapy completed afterwards. In some of these patients or in people who may be either medically inoperable because of comorbidities, or there's a question of whether complete cytoreduction can be achieved, we may also recommend chemotherapy first. And that's, again, with the hope and the expectation that if there is a good response, that they'll be able to still receive cytoreduction and HIPEC following chemotherapy, but knowing that getting a response will be important for those particular patients. The other subtypes, the sarcomatoid histology or the biphasic, which has elements of both epithelioid and sarcomatoid, are a little bit more aggressive and difficult to really treat effectively with surgery as a primary therapy. So most of these patients will be offered systemic therapy first. Patients with very limited disease or really a significant response to therapy, including those with biphasic type that maybe kind of behave or have a little closer kind of similarities to the epithelioid patients, may see a response and may also be offered cytoreductive surgery and HIPEC. But again, these are generally after chemotherapy has been given in this group of patients. I don't want to spend too much time talking about it just because we have Dr. Mogal went over this in great depth earlier, but just in terms of the goals of surgical management for this now a different diagnosis really is unchanged in that we look to achieve a complete cytoreduction, removal of all gross tumor disease that we can see within the abdomen. And again, it's through the same process of that larger surgery, open operation, stripping a lot of the peritoneal lining, and any sort of organ involvement that there may be, followed by the HIPEC phase, which is installation of the chemotherapy drug. And for mesothelioma, typically in our practice, that's the cisplatin that you saw earlier on the slides that Dr. Mogal had shared. So in conclusion, peritoneal mesothelioma is a rare cancer of the abdominal wall lining. I think it's really important that expert pathologic diagnosis and multidisciplinary management are had to appropriately select patients for cytoreductive surgery and HIPEC based on both the tumor subtype and then the extent of disease. And again, aggressive surgical removal, intraperitoneal therapy, and systemic therapy are all required to offer long-term survival and quality of life for patients with this disease. So I'm happy to answer any questions. Yep, we have one right here.
When you talk about stripping the inner lining or the peritoneal lining inside the abdomen, what is the regrowth rate of those cells so that they can act as a sieve or a barrier to other growths within the abdomen?
Yeah, so the question is, when we perform peritonectomy or remove the abdominal wall lining, what is the, I guess, rate of regrowth so that you can perform the normal functions of those tissue? And the question mentioned protect from further growth there. And I think truthfully, we don't have a complete understanding of that question. What we do know is that when we remove the peritoneal lining, the scarring that will form is not really going to completely recapitulate the kind of initial form and function of the peritoneal lining. So there will be scar formation that will have a different function. In terms of the protective effects, you know, it's hard really to say if there's going to be any additional protective effect that happens in the postoperative period, but often we don't expect the whole peritoneal line to grow back in its original form. So for patients who may have an operation and then a second operation is done sometime in the future, for instance, we don't expect to see that it'll look the same as if it had been the first trip to the operating room for that patient.
My understanding is that one of the reasons for scraping the peritoneum during site removal or debunking is so that the HIPEC chemicals can then have more access to the cells in the peritoneum lining. Is that what also then forms the scars?
Yes. So when we strip the peritoneum, part of it is that we strip places where there's disease present. So we want to remove all the disease. And then there's been a couple allusions to the potential for microscopic disease or cells in the area. And when we remove the peritoneum, it gives the HIPEC drug access to the underlying tissue and any potential microscopic disease that may be there. And yes, that process does create a lot of scar, both from the process of surgery itself, but also the drug can be a little bit, is irritating to that tissue.
Do you differentiate in these comments about peritoneum about fatty infiltration, peritoneal fat?
So that's an interesting question. So there are areas within the peritoneal cavity that there are fat that either lines or overlies the organ space. We still think of it as there's an actual thin layer of peritoneum that overlies that fat. So for instance, one of the parts of the operation that Dr. Mogal had mentioned, we do an omentectomy as a routine as part of the cytoreduction surgeries. The omentum is a fatty kind of layer that overlies the colon and all of the small bowel. The omentum has a dual layer of peritoneum on both the front and the back of it. And so we essentially remove the fatty component, but also the two layers of peritoneum in doing that portion of the operation in and of itself.
So I won't go into detail, but I assume that's not necessarily the case for metastatic disease from other areas. If the omentum's involved, that the same cytoreduction surgery would not be the same, in other words.
The surgery actually is consistent regardless of the I guess the origin of the cancer. One of the reasons is because this pattern of disease spread has a commonality between secondary disease that's spread to the abdomen and also primary disease like in peritoneal mesothelioma. And there's a lot of theories about why that is and how fluid kind of moves through the abdomen and just where cells tend to settle. But we do actually see a lot of similarities between across disease groups, and that's why there is some standardization to what the surgery looks like.
You mentioned the melanoma. Can you expand on that a little bit?
Not very much. So melanoma, uveal melanoma in particular, does have some association with this BAP1 protein. That represents a relatively small group of the people with BAP1 mutations represent a small group of mesothelioma patients. However, it is a known association. And so as part of taking a history, it's just important to ask these questions just to consider that as part of what other sorts of risks patients may have.
Okay, so it's a melanoma marker then? Is that
That I'm not, well, I think if you had a germline mutation, yes, but if you have a mutation within your mesothelioma, but you didn't have, like a mutation throughout if you weren't a carrier for that, you wouldn't necessarily be at any higher risk for melanoma. Hopefully that explains. All right.
One question here. I'm not sure whether it's for you or for Dr. Mogal, but is there any thought to looking at doing HIPEC as opposed to HIPEC, where you do the pressurized interperitoneal aerosolized chemo
Yes.
versus doing the really aggressive surgery that's required for HIPEC?
May I table that question? We have a clinical trials update at the end of the program today that will touch on that a little bit. And if there's more questions after that, maybe we can talk about that.
That would be great. Thank you.
Great. If possible, was there one other question, or may we move on to the last? I think we're a couple minutes behind before our break. Happy to answer any questions over the break as well. But I'd like to welcome up Kerry McMillen. She's a registered dietitian here at Fred Hutch. She's the senior manager of the clinical support care with the Fred Hutch Cancer Center. She's also a board certified specialist in oncology nutrition, and she's the lead nutritionist for the HIPEC program, and we'll be speaking today about the role of nutrition in the HIPEC treatment. Thank you, Kerry.
Hi, everyone. Thank you for the kind introduction. And it's really great to be here this morning. And I will move through my talk with the goal of just giving you really practical advice on how you can understand and incorporate nutrition, no matter which stage of treatment you may be in, whether you're about to undergo HIPEC, things to think about while you're going through HIPEC or CRS procedure, and also in follow-up and survivorship, because those are all areas where nutrition is very important. So thank you very much. Oh, how do I advance this? Okay, bear with me. While I'm waiting to advance my slides, I just want to, there we go, say that we're very lucky, and Dr. Mogal, Dr. Sharib, and others have spoken quite a bit about the role of the multidisciplinary team. And we're really fortunate here at Fred Hutch to have dietitians. We have 2 actually embedded in our HIPEC clinic. So I just want to give a thank you to Dr. Mogal and Dr. Cohen, who co-lead this program, for including nutrition regularly. So to move through the talk and really to think about why nutrition is important when you prepare for HIPEC, what we're really looking at is trying to maximize your nutrition status. As Dr. Cohen mentioned, many times you're getting chemotherapy prior to the HIPEC procedure. And this chemotherapy, oxaliplatin, 5-FU, et cetera, all have significant nutrition impact symptoms. And really what we want to do is make sure you're working with a dietitian to maintain your strength, lean body mass, and nutrition status as you're preparing for your surgery. So if you're not at Fred Hutch, or even if you are and you're not yet connected to a registered dietitian, I would definitely take this opportunity to encourage you to speak with the dietitian to understand how you can really maintain your nutrition status through your preparative regimen. Additionally, the break from chemotherapy pre-surgery is a great time to improve eating and your nutrition status. And I know we're fortunate to have one of our rehab colleagues in the audience today, but what we really are focusing on is the importance of nutrition and physical therapy to regain muscle and strength. So when you think about that, it's really breaking it down into making sure you're having adequate calorie intake, but really making sure you're focusing on your protein. And I do want to call out that that does not mean you have to become a carnivore. That means that you can even vegans can meet their protein status while going through therapy. And I think that's an important consideration because we really do want to make sure that we're honoring cultural differences, making sure individual diet preferences are taken into account. And really what we want to encourage is that you're including a protein source with each meal and snack, and even considering including protein in fluids such as smoothies, etc. I do want to point out that oftentimes when you're diagnosed with a malignancy, you have very well-meaning friends or family that come out of the woodwork with their own diet nutrition advice. And or there's a lot of information on social media, the internet, et cetera, that's encouraging you to do diet changes that may not be evidence-based. We're going to get into myth busting in a moment, but I just want to put the caveat out at the beginning of the talk that when you're diagnosed with a malignancy, it's really not the time to make a significant diet change. It's really important to think about maintaining your nutrition status or improving it. So again, what I really want to focus on is not necessarily the number on the scale, but when I talk about maintaining weight, what we're really thinking about is your strength. We really know that your nutrition status heading into surgery is one of the most important predictors of outcome, and that's been mentioned by everyone here so far. So I want to bring up a concept also that's really important and your care team will talk to you about. And I don't know if you've heard of this yet, but it's called immunonutrition. And what it is taking certain nutrients before surgery can help support your immune system. And so it's a component of what we call ERAS, enhanced recovery after surgery. But paradoxically, we're also talking about nutrition pre-surgery too. So they're both important. But what we know is that this is a shake that you can take. It's a nutrition supplement. It's a regimen where you take a specific supplement 3 times a day for 5 days before your surgery. And your team can go over exactly where you find these. They're commercially made. It's not something that you're getting at a strange location or something like that. We carry it at our pharmacy. And what we know is that taking the immunonutrition drinks the 5 days before your procedure can really help reduce surgical complications, infections, and also your length of hospital stay. So I want to emphasize that this can be a very important part of your preparative regimen, and also to note that this is not meant to be a meal replacement. This is in addition to your already consumed meals and snacks, and it's just really allowing you to boost your nutrition status. I have a link here to our handout that's publicly available, and it's just called Immunonutrition Before Surgery. Not a very creative title, but yet explains what the handout is about. So then I want to move into a discussion about the nutrition needs after HIPEC surgery. This is in all caps for a reason, as Dr. Mogal mentioned, and others have as well. The nutrition complications after surgery are not to be underscored. We really do want to make sure that your nutrition status after surgery is maximized, because this is really what helps your healing. And what's really interesting is that your nutrition needs, and by that I mean your calorie and protein intake, are extremely high after surgery. And this is often something that's confusing because we're used to wanting to eat because we feel a hunger signal. And you may not feel that hunger signal as your abdominal cavity has just been opened up and reworked, for lack of a more scientific term. And so as you're healing, though, we know that you need appropriate calories and appropriate nutrition and protein to really maintain your nutrition status. And during that approximate 8-day nutrition inpatient or your inpatient stay, you will have a registered dietitian that will consult with your surgeon to manage your nutrition care. And Dr. Mogal did mention that at times when people are not able to eat by mouth, there may be an indication for either IV nutrition or nutrition through a feeding tube. But the timeline for what you need and the recovery in detail is really quite varied by individual. And it really does start to improve about 1 month after surgery. And that's something that you'll be working with your dietitian as well as your care team very closely on as you start your healing process. And then it does take about 3 to 6 months to get back to your baseline or how to learn to adapt to your new baseline after surgery. So just to expand on this a little bit more, I just want to speak to what the role of the registered dietitian is and some examples of how we might be helpful. So as I mentioned, it's very important to meet with a registered dietitian. In the hospital, they'll actually come directly to your room to talk to you, start giving you options for what you might be able to try in small quantities. But the way we have our nutrition program set up here is that you're going to meet with a dietitian prior to your HIPEC surgery and then weekly after your HIPEC surgery. The reason that we're meeting with you so frequently is we really want to assess on an individual basis how and when to transition back to eating and how do you plan to expand your diet during this process. We can really help manage expected side effects that you may experience, such as poor appetite, nausea, and one of the most common ones is feeling full quickly after meals, or something that we call early satiety. So this could be you're used to eating a normal sized plate of food, and now you're feeling full after about half a cup of food. And as you can imagine, this might make it hard to meet your calorie and protein needs if you're filling up on foods that are, this big instead of this big. So we'll give you tips such as, small frequent meals, maybe 3 meals a day isn't as helpful to you right now. So we might encourage you to eat or drink something every 2 hours. Another thing that comes up is making sure you're spacing apart food and fluids. If you only have so much room in your system and you fill up on 16 ounces of water right before your evening meal, it's going to be really hard to consume dinner. So that might be a practical strategy. We also know that liquid foods move through the digestive tract, specifically the stomach, much faster. So it might be for a while that you're having more soups or smoothies as you transition back to more of a solid food-based diet. And then we're also thinking about if you're feeling full quickly and someone says to double your portion, that's not very doable. So instead, we're thinking of things like maximizing your calorie dense food and fluids. So I just put up a snip of our handout that's called Make Every Bite Count. And the idea here is that you're really maximizing your calories in each bite. So think of things like peanut butter and nut butter. You don't have to eat a lot of it to really have a big bang for your buck in terms of calorie density. So moving into survivorship, and I know I'm going quickly through the spectrum just due to time and overview, but what we're really thinking about is maximizing your quality of life, and diet and physical activity, as we already mentioned, are very linked. So as Dr. Mogal already mentioned, do some physical activity and then go take a nap. But we also want to make sure that you're eating as part of your recovery. So again, just in terms of energy balance, we know that it's very important to maintain adequate calorie and protein intake and exercise because both components are needed to regain strength and muscle mass. It's very important to continue working with your dietitian as well as your physical therapist to get appropriate exercise-based regimens. They are the experts in this area. And it's also really important to stay hydrated. People don't always realize how much dehydration can contribute to fatigue. So maintaining your hydration, which doesn't have to be all water, really any liquid counts. So that's an important item to consider as well. And then I also want to just take a moment to think about, this is where the individual nature of your surgical results come into play regarding your nutrition status. It's every surgical outcome is different. And there may be different, organs that have been manipulated or removed after your HIPEC surgery. So we really want to work with you to understand how to best modify your diet. So for example, if you are at risk of having small bowel obstruction, we would want to work with you on the appropriate diet modification to ensure that you don't become completely obstructed and avoid an ED visit. If you have short gut syndrome, it's very important to think about how you stay hydrated, how you can tolerate small frequent meals, and specifically maintaining vitamin and mineral needs through appropriate supplementation. And then if you have an ostomy, really to learn what foods and meal patterns are best tolerated. All of these really go into maximizing your quality of life by really making sure you have a way to strategize and understand what works best for you. So let's move into myth busting. I don't know if any of you have heard some of these ideas or concepts, but I just wanted to bring them up because I think it's really significant. One of the most common things I get questions about, and I know my team gets questions about, is that you have to now avoid all sugar because sugar feeds cancer. Sugar feeds every cell in the body. And so it's really not something where when you have a cancer diagnosis, you need to cut out all sugar. There's actually not evidence to support that. So hear this, there's no need to overly restrict carbohydrates. It is a very important source of energy and fuel in your bodies, and it's very difficult to meet your caloric needs without any carbohydrates. So eliminating your carbs from a healthy, well-balanced diet is not indicated. However, it's always a good idea to avoid or limit high carbohydrate, non-nutritive foods or fluids. So standing up here as a dietitian, if you were to say, I'm going to get my carbohydrates from eating whole grain breads, fruits and vegetables, or eating, soda and Twinkies all day, I'm going to go with the former because not all carbs are created equal. So certainly we can also work with you. Comorbidities were brought up, managing if you do have diabetes, we want to manage your glucose levels. That's important for surgical outcome as well. But again, the sugar feeds cancer and you need to avoid all sugar, not needed. You may hear about other fad diets where people are talking about you need to drink alkaline-based waters, you need to avoid certain foods, you need to be on a ketogenic diet, or you need to fast. There are no studies that really validate these approaches to GI cancers. I actually just had a patient call me, not from within Fred Hutch, but was wondering if they had a dietitian that could aid someone through a 21-day water fast. It's not indicated, and it was actually could be very harmful because you're not going to be able to maintain your nutrition status with that approach. Also, the other category that people really have a lot of well-meaning family and friends that talk to them about starting supplements. And that could be anything from, you need to drink spirulina every morning to you need to take fish oil 8 times a day. We really know that current research does not support taking supplements to prevent cancer. And the bottom line is that there can be a lot of nutrient medication or organ toxicity, also risk of purity depending on the type of supplement. So what we would really encourage you to do is to work with your registered dietitian and medical team to determine what diet modification or supplement may be indicated for your specific condition. And most importantly, especially pre-surgery, do not start any supplements without your approval from your physician. Some of these supplements can actually influence clotting or platelet activity, which is not something that you would want to put yourself at risk for prior to surgery. I wanted to make sure I left you with some really great resources for some more nutrition information. And we do have a great website that's sponsored by Fred Hutch called Cook for Your Life. I'm not sure if any of you have heard of this. Okay, great. I see some nods in the audience. So this is really full of recipes that you can even dive into by condition. So what can you eat if you have diarrhea? What works if you have trouble swallowing? What are some good ideas if you've had taste changes? So I'd highly recommend that. And then there's also our national organization websites, American Institute for Cancer Research, where you can really get some great tips on cancer prevention and survival, as well as American Cancer Society. And then all of our patient-facing education is on our Fred Hutch public-facing website. And if you happen to be looking for a dietitian and you're not a Fred Hutch or UW patient, You can find a registered dietitian through our national academy, and that website link is located right here. So with that, I'm the last thing that's standing between you and nutrition, because I know we're having a break, but I am happy to take any questions if there are some.
Before I had my surgery, I looked online and I found a research paper that suggested limited caloric intake before chemo and during chemo. And it said that it really could help the chemotherapy to get the cancer cells, since they are more, they do need a better feeding schedule.
Yeah, so it's a great question, and thank you for bringing that up. When people talk about fasting, one of my first questions I ask them is, what type of fasting are you talking about? There's intermittent fasting, there's multi-day fasting, there's time restricted eating, and there's various amounts of research about all of those topics. Specifically, what we would want to look at is your individual cancer regimen and what particular chemotherapy you are taking, because the tumor response and the therapeutic effect of the chemotherapy regimen is not one and all for all different types of cancers. So what might work for a breast cancer regimen versus an ovarian cancer regimen versus a glioblastoma or a bloodborne cancer like leukemia, there's all kinds of different research. So that's why we really recommend an individualized nutrition appointment and consultation with your physician to really ensure that we understand that there's research and evidence-based information for your specific cancer and regimen.
So, thanks, Kerry. That was a wonderful talk. One of our virtual attendees had a question about nutritional supplementation or supplements, nutritional supplements during their treatment journey. And they were not talking about the weird supplements, they're talking more of like the standard multivitamins and minerals like vitamin D, B12, vitamin C, etc. What are your thoughts on continuing those versus stopping them?
Oh, that's a great question. Thank you for asking. So what we would really recommend in terms of supplement needs is taking a look at someone's nutrition status. And in terms of just taking a multivitamin, especially when you're at risk for having reduced overall nutrition intake, we would actually encourage you to take a standard multivitamin with nutrients not really exceeding 100% of the daily value. And that's what you find on the back of the multivitamin. The reason being is that when you're not eating as broad of an array of nutrients, you can actually have micronutrient deficiencies, and we would want to try to prevent that by taking a standard multivitamin. A standard multivitamin will have vitamin C, vitamin B12. There are certain conditions that you may be at risk of vitamin B12 deficiency. So for example, a lot of vegan patients may have risk of vitamin B12 deficiency, or if you've had prior surgeries or other parts of organs that have been resected, you can be at risk of B12 deficiencies. We're seeing this is maybe going too deep into the weeds, but we do see an increased numbers of patients these days who have had bariatric surgery. And in those situations, when you're limiting your absorption, digestion, or nutrient utilization, you can see people who have had their supplements post that procedure mismanaged and come in pretty significant nutrient deficiencies. So again, I don't want to, as a broad stroke, I would say a multivitamin is likely very well indicated. However, we again want to take an individual look at your profile and make sure we have that open dialogue to understand what are your questions regarding supplement use, and then really develop a tailored program to what would best meet your needs, your medical conditions, and we would work with your physician if there are any supporting labs we would want to draw. So for example, vitamin D. Most of us here in the Northwest, we know that the last 3 weeks have been great, but vitamin D deficiency is actually quite common, and taking 1,000 units of vitamin D is a fairly common recommendation. And insurance, sadly, except if you have certain pre-diagnosed conditions, doesn't cover a 25-OH vitamin D blood draw. So just taking a standard vitamin D supplement, there would be very few contraindications to that one.
Thank you.
Thank you so much. I'm happy to answer any other questions in the hall.
So we have a little bit of catching up to do with time, but let's take a quick break and potentially, it's about 10:54. So maybe we reconvene in a little bit after 11, so 11:05. We should be able to catch up in the second half. Please feel free to go across the room and grab some boxed items to eat, I guess, because they had to clear the buffet breakfast, and then feel free to use the restrooms, etc., network with folks, and we'll see you back here in 5 after 11. Thank you. Settle down, everyone, and we can, hopefully we still have folks that are on Zoom. But it is my pleasure to introduce our next speaker, Kathy Plakovic. Sorry about that. I knew I was going to mess it up. So Kathy has been with Fred Hutch Cancer Center for several years now. She leads as one of the advanced practice providers, the palliative care team. And she's also a teaching associate with the Department of Medical Oncology at the University of Washington Medical Center. It's my distinct pleasure to have her speak today about palliative care in patients that have peritoneal cancers.
Good morning, everybody. Today, I'm going to talk to you a little bit about how palliative care, how palliative care can help you live well. And I'm going to start by quickly going through my slides so you don't have to sit here any longer than is necessary. And I'm going to try to move quickly through my slides. There we go. So this is just briefly what we're going to talk about today. I won't go into that in any more detail, and we'll just start out here. So when you're living with cancer, there's a lot going on. Palliative care is really an extra layer of support for you and your family. We work closely with your oncology teams to make sure that you're feeling as well as possible and that you have the best care possible. We're here to address all of your needs, whether those be physical, emotional, or spiritual needs. A big part of what we do is symptom management. And as you've heard from other speakers, there are symptoms that are involved with the several different treatments that we have to offer. Our goal is to really focus on your symptoms so that your oncology team can focus on your disease. Now, your oncology team, they're great at doing primary palliative care, and we leave a lot of that up to them to treat nausea and vomiting, diarrhea, constipation, all those symptoms that we expect with this disease. But where palliative care, specialist palliative care gets involved is for patients that are having multiple symptoms or symptoms that are not being well controlled with the standard regimens that we have. So prior to starting any cancer treatment, we work closely with your teams to make sure that you feel as well as possible. And then we follow along with you after treatment has begun. For patients undergoing HIPEC, as you've heard, most of the symptoms that occur in about 3 months after the surgery. Those can be things like nausea, vomiting, diarrhea, constipation, fatigue, and pain. These are also common after other treatments that we give, including chemotherapy. We understand that symptom management is not one size fits all. Everybody and every body is different. And so we really take the time to tailor the medication or combination of medications that are needed to really help you feel well. And it's not all about the medications. We use a multi-pronged approach to make sure that you're feeling as well as possible, including non-pharmacological things that we can do. Our goal is to really help you live as well as possible and spend time at home with your family and avoid the emergency department. It's not uncommon for patients with serious illness to have psychological effects related to having this diagnosis, including depression, anxiety, and existential distress. We work closely with our team here at the Cancer Center, which includes social work, psychologists, and psychiatry, to make sure that any issues that you have that are impacting your care are well addressed. You've already heard from our folks in oncology nutrition, and palliative care and oncology nutrition fall under a bigger umbrella of supportive care services that are available here at the Fred Hutch. These include other things like spiritual health, oncology rehab or physical therapy, and integrative medicine. Our integrative medicine team includes naturopaths, acupuncturists, and a skilled nurse practitioner that does more mind-body work like meditation, progressive relaxation, and guided imagery. And we work all together as a team to make sure whatever needs you have are being met. Communication is key to having good quality cancer care. Sometimes it's hard to know who to call, especially when you have many people involved in your care, right? You've got your oncology nutrition folks, you've got surgery, you've got your medical oncologist, and then you may have palliative care, and you think, who should I call next? Well, you can always call palliative care first, and we will try to address whatever concern you have. But sometimes patients call us and we say, you know what, this is a question that's better suited to your oncology team. So what we do is we reach out to your oncology team on your behalf so you don't have to make multiple phone calls. We also copy your other team members on all of our notes so that everybody's on the same page and knows what we're discussing with you as well. You have a say in your care, and we think it's important as we get to know you over time that we understand what's important to you. We encourage you to talk to the people that you love so that everybody understands the care that you want. We can offer family meetings with your family just to make sure everybody has a chance to hear the same thing. And we can also do joint visits with your oncology team if that is needed. I now wanted to share a couple patient stories with you that I think will illustrate better how palliative care can be a part of your team. Julie had ongoing nausea and vomiting that had not responded to multiple medications. She was referred to the palliative care team for symptom management. She had previously reported that she was having daily bowel movements, but when we explored with her a little bit further what that looked like, she was having very small bowel movements and never felt like she had completely emptied. We reviewed her CT scans, her latest CT scans, and they showed a significant amount of stool burden in her abdomen. And it's important to note the radiologists usually don't mention that on your report unless it's really, really, really bad. So we worked with her to find a regimen to kind of help get her cleaned out, and then an ongoing bowel regimen so that she was moving her bowels regularly. And once she was no longer constipated, her nausea and vomiting stopped. These comments were recently shared by a patient to one of my colleagues, and I'm just going to read them verbatim. Patients often tell me that they have a hard time believing that I'm as ill as I am. I tell them the care I am receiving makes the difference. After almost 2 years with palliative care, I feel they know what's important to me and do a great job helping me to achieve my goals. For me, a lot of it is pain management, but that is far from what they do for me. They address my psychological as well as my physical needs in a variety of ways. I could not be more grateful for this outstanding group of people. And here's just a few quotes that we have heard from patients and families. I've gotten my life back now that my pain is well controlled. Thank you for your compassionate and pragmatic support. And I wish I'd seen you earlier. I hear that one a lot. This is our entire palliative care team. We have a robust team here at the Fred Hutch, including 2 physicians, Dr. Loggers and Givens, 4 nurse practitioners, Molly Arnold, myself, Megan Blasey, and Kimberly Harlow, and 4 fabulous registered nurses that do a lot of the phone consultations with our patients before they bring their cases to the providers. And that includes Jody David, Megan Ward, Molly Taylor, and our newest nurse, Jessica Bradley. The phone number up here, you can call if you choose option 4 when you get the phone tree, that goes to our nursing staff. So if anybody has any questions after today's presentation, you can call and the nurses will be happy to address those for you. You can ask for palliative care at any stage of serious illness. And I hope this brief talk has given you a better understanding of how palliative care can be a member of your team. We can make a plan for your care and help you feel as well as possible. I'm happy to take any questions. Yes. No, so when you make your initial appointment, you can, if there's somebody you know or have heard of, you can certainly say, I would like to see that provider. And then once you're on our team, we do our best to have continuity of care so that you see that same provider each time. That answer your question? Any other questions? All right, well, thank you so much. Thank you.
Okay, moving along. So our next speaker, actually, this is one of the most favorite part of the events that we do every year when a patient comes up and shares their story, shares their experience and their journey. So it's my pleasure to welcome one of our patients that we met at Fred Hutch a little more than a year ago, who was diagnosed with malignant epithelioid mesothelioma, incidentally while having another operation for a presumed gynecological malignancy. And without much ado, I will welcome Cleome, who we treated at Fred Hutch Cancer Center, to share her story and her experience with all of you.
Thank you, Dr. Mogal. Good morning. Well, yeah, we're still in the morning. So my name is Cleome, and I'm here to say that I have received the finest care possible because the expectation I had this inkling. My cancer journey actually started in BC, Canada, when I was working on a farm there as a cooperative and worked really hard. And I found out that my first love, my boyfriend in high school, had died of colon cancer. And I kept thinking to myself, I've got cancer. This is ridiculous. You know, I have a bachelor's in biology. I know this is just silly thinking, but I kept thinking, I've got cancer. Well, I didn't tell anybody that. My God. Because I had on my way of getting into Canada, you have to have health tests. They thought I had something like TB in my bladder because I was postmenopausal and I had some blood. So I had a cystoscopy, I had an ultrasound, nothing. Everything was good. So I got in, got my green card. And but I had this heaviness kind of in my lower abdominal area. And I think, oh, I have cancer. Well, I had some pain. So I had another ultrasound. They found nothing. And I said, okay. And you know, the pain went away. It was just sometimes a vague discomfort. And then COVID hit. Well, with the farm, we were growing a lot of vegetables. We're like a market garden where we put them on the back of the truck and take them to market. What doesn't sell at the market comes home and I make it into jams and preserves and I dry it. I mean, we were really busy. Had goat cheese, made soap, and we had COVID. And I was teaching school part-time too. So it's like, first off, I don't have time to deal with this. Second off, my symptoms are so vague. What am I going to tell the doctor? And if you're having to do it over Zoom. Well, Zoom is not the best platform. And I just felt like I had nothing really that we could talk about and I could just keep working. And so I did for a long time. COVID in Canada, the kids went back to school the next year. I had a half-time job and I was still working full-time on the farm. I still wasn't feeling really great. Felt like, you know, there was like 5 flights of stairs from where my classroom was to the admin because it was built on a hill. Man, those stairs were getting hard to do. I just get about 3 flights up and it felt kind of breathless. This wasn't me. I usually run around like a squirrel. So even one of my friends kind of noticed. And then one day at the end of June or one night, I had this terrible pain. And I said, something else. I'd had vertigo before, and in Canada, it's free to go to the ER. It's free, all your medical care. So that was good because I told my husband, I said, okay, I need to go to the hospital. And I said, oh, possible gallbladder, not uncommon. And they did the bedside ultrasound. He said, couldn't find anything. He said, well, you know, I'm not really very good at this. We'll get you a real ultrasound. So a couple of days later, I went in and they were doing all this upper abdominal stuff. And he just decided to do a more complete job. And he said, do you mind if I do a pelvic ultrasound? No, go ahead, I'm right here. And he said, I see a mass. Now, I know a lot of times the texts don't tell you those things, but I could see the concern in his face. And he said, I said, okay, it's good to know. Kind of explains the heaviness I was feeling in my abdominal area. Maybe it was cancer. So the doctor then wrote me a referral. Now this is, Canada's great. You can go in the ER. I didn't pay anything except for parking. Literally, they were pretty quick on there, but some of the things are still done kind of like by fax. So the first referral got lost. 3 weeks later, he wrote a second referral to the surgeon. And then things started rolling. I had a CT scan, I had an MRI, I talked to the doctor, and they scheduled surgery for September. And good, because man, I was beginning to feel pretty bad. I couldn't eat real well. I was tired all the time. I was losing weight, which has not been my problem. So I went in and I had the surgery. Well, they didn't do a biopsy first. So we thought we were dealing with ovarian or uterine cancer because I had a 10-centimeter mass. That's 4 inches. That's big. And so they took that out. And the next day I talked to the doctor and he said, the cancer was very extensive. I couldn't get it all. And I was pretty dead. And he thought there was the mucinous ovarian cancer. And it's, the prognosis sucks. So I was pretty devastated. And I called my kids, 2 of which are here today. They were my huge support system. And I this first time I ever really cried about getting cancer because I'm pragmatic. I mean, I grew up on a farm. Farm kids get killed. Farm adults get killed on equipment. And, you know, I knew these people and I have a motorcycle. I mean, like, how smart am I? So I thought, okay, I know that they were really upset, but we didn't have the pathology back. And so that took 3 weeks. That was too long. But 3 weeks later, we found out it was peritoneal mesothelioma, the malignant epithelioid type. And I said, okay, maybe that's better. I might not, that might be, I've read, I mean, my degree's in biology. I read all this research. I can't keep away from it. So then we went, my husband decided the thing he does better than anything else is get on the computer and find stuff. And he went and found this group called asbestos.com. So anybody that has asbestos cancer, these guys are phenomenal. They arranged for someone to advocate for me. They got me connected with, was SCCA, now Fred Hutch at the time. And they just got the ball rolling. And so in Canada, I was going to have a phone conference with someone because they get like in BC 4 or 5 cases of this a year. They're highly selective getting to get the surgery. And I read by then, I want this surgery. I want a chance. I'm not ready to go quietly into the night. And so I was going to go kicking and screaming. So I was going to have to go to Quebec. I don't want to go to Quebec. My kids are here in Bellingham, so we decided to come back to the United States since I'm dual. And I started my chemo before I had a phone consult there, which was great. And just things happened. And I talked to Dr. Mogal, Dr. Cohen, and I said, I want the second surgery. I was really adamant. And I thought, I'm 62 years old. But Dr. Mogal said, well, it sounds like the only problem you have is cancer. Yeah. Yeah, you know, I didn't have any comorbidities, but I was 62 years old. And in Canada, that would have probably kept me out of getting the surgery and the HIPEC. But I had 5 rounds of chemo. It went pretty well. Feeling pretty good about this. Surgery in the hospital 10 days, got out. The first time around the block I live on was pretty tough. but I just had no post-operative problems. I mean, that's stupid NG too. I ended up with a colostomy, but that's no big deal. I mean, I felt good again. I felt like I could do things again. And so having the surgery was like the best thing that ever happened. First off, I'd probably be under the dirt by now. Actually, my kids would have turned me into dirt by now because their plan is to compost when I'm done. Put in their garden. I mean, let's be realistic. They're farm kids, right? And, but I got the best care. I had this whole team you hear about, the nutritionist, the PT person. My favorite is Ava, the wounded ostomy care nurse. She's so sweet. Dr. Mogal, Dr. Cohen, if I ever had a question, when I got shingles, I could just send a picture and they give me my medication. So the care here is just phenomenal. And I have now, I only plan a year ahead. Honestly, this is a fatal cancer. I'm not going to live to be 100 like I'd planned, probably. I might, we'll keep working on it. I exercise all the time. I have, sometimes they send me on forced marches up the top of the mountain. My girls, two of my girls and my son here, we've already paid the money. We're going to Mount Baker and summiting in 2 weeks. I know, I said the same thing. Then we're supposed to do this hard section of the Pacific Crest Trail here in Washington. Clover, my daughter, said, "Oh no, Mom, what happens if 2 days in and you can't make it?" It's like, I'm gonna make it. It's not been my issue. I'm just slow. We might take an extra day. I'm getting my motorcycle repaired because I'm going to ride it for a while. So I'm going to do some trips on my motorcycle, trying to talk my son into fixing his so he can go with me. We're going to I plan to go back to Europe this summer. I did spend October of last year, part of November, with my son and his family in Italy, Germany, and Spain. My bucket list is really to spend time with my family and my friends and do those things that we can enjoy together. So, you know, people say, "Oh, you can travel." Where do I really want to go? I mean, I want to go with, not to. And so I really feel like I have gotten a full life back. It may not be as long as I planned, but like I said, I farmed. It's not a good way to live a long life. And I'm really looking forward to all the things that I've been able to do because I had this surgery and this opportunity. And so if any of you are looking at this surgery and thinking, "Man, that's scary," yes, it is. It was, but my results have been that I'm so much better than before I had it, that I would do it again in a heartbeat. All right, any questions? Okay, thank you.
Well, thank you so much for that story. Really heartwarming and inspiring. And hopefully, if there are any questions, I'm sure that people would feel more maybe comfortable coming up personally. But really, thank you again. That's obviously, you know, the reason why we do these sorts of events, and the most exciting portion for us. The next couple speakers, I think actually Deborah's on.
Virtually, yeah.
So coming to us virtually, first is Deborah Shelton, and she is the Executive Director of the ACPMP Research Foundation. And for those who may not know, both Deborah and Adele, who will come after with ACPMP and PMP PALS respectively, are both very important patient advocacy and research foundations that are associated with penicillin and peritoneal malignancies. So happy to welcome Deborah. I think I'll stay up here while she's speaking.
Great. Thank you. Thank you very much. And thank you to the conference organizers, Drs. Cohen and Mogal, Ritu. Really appreciate all of your help. Special thank you to the patients and caregivers. You inspire me and my spouse every day. I am going to share my screen, or at least attempt it, so bear with me 1 second. Put it in slideshow mode. And There we go. I'd love to clear this so I can see. There we go. So great. Can everyone see my presentation? Just give me yep, okay, great. So I will try to, I know that we're low on time, but I'd love the opportunity to do a quick kind of flyover and tell you a little bit about the Appendix Cancer PMP Research Foundation. We are a nonprofit organization. We were created a few years ago, back in 2008. We are an all volunteer led organization. All of us have been directly affected by cancer, and most of us, including myself, have been directly affected by appendiceal cancer. Our mission is really twofold. One, we fund and support research to discover new treatments for appendix cancer. And our mission here really flows from our founder, Lisa Luciano, who you see here, who was really focused on finding a cure for appendix cancer and pseudomyxoma peritoneal, or PMP. And that really is a core part of our mission. The second part of our mission is we fund and support educational programs for everyone, healthcare professionals, patients, caregivers, families, to really keep pace with the evolving science and also to increase awareness about this very rare cancer. I want to say, and I always like to say, the lifeblood of our mission, of our organization, it's really donations, and we are just so very grateful for the generosity of our donors. Most of our donors are patients and caregivers, families affected by appendix cancer, and we appreciate them so much. Just to put a face on the organization, this is who we are. We are a lean and mean operation, for sure. We have our president, James Carroll, and vice president, Judy Culbertson, both of them. Judy lost her husband to appendix cancer. That was Jim Carroll's best friend. I am the executive director. I also sit on the board as a vice president. I came into this world of appendiceal cancer when my spouse was diagnosed in 2018. We also have our only two paid positions here. We have an operations coordinator, Alyssa Strackbine, who lost her fiance to appendiceal cancer. And then we have our part-time admin coordinator, Jamila Slade, who has a lot of family members with history of cancer, but she herself and her family has not been affected directly by appendiceal. I just want to say, for me, after 25 years experience in drug development, really from bench to bedside to FDA approval, marketplace of various drugs, including in the oncology space, until my spouse was diagnosed, I had, and neither had she, ever heard of appendix cancer. And that's why once we got that diagnosis and I learned how little awareness there really is out there, I just kind of came into this full throttle. So I work full time for the foundation, but I donate all of my time because I really want those dollars to go to our mission. We have a medical advisory board at ACPMP. Here they are. Our chair is Dr. Lambert, who some of you may know. She's at Huntsman. We have a nice mix on our medical advisory board of surgical oncologists, pathologists, and medical oncologists. We are currently, just as of last week, a longstanding medical oncologist has rolled off. And so we're in the process of rolling on a new medical oncologist. But this group really does tremendous work for us. They help us with all of our educational materials. They help us keep up with the evolving research and science. They serve as ad hoc reviewers for our research grant program. They really are available to us for any kind of discrete questions that we have. And we often get their advice, counsel, as we're helping patients navigate their new diagnosis and looking for medical help. We also, in addition to the Medical Advisory Board, ACPMP has a Scientific Advisory Board. This is a board that we just established last year, and their focus, primary focus, is on our new research grant program. Our chair here is Dr. Holavati at Vanderbilt. Some of you, if you attended our webinar last month on genetic testing, would have heard Dr. Holavati and some interesting work she's doing. And then we have Dr. Overman at MD Anderson and Dr. Vatanopoulos at Wake Forest. And we supplement our Scientific Advisory Board with ad hoc reviewers for our grant program, depending on the specific subject matter expertise that we need to review and score our proposals. That research grant program, we just started. This is a new program for us. It's administered internally with our Scientific Advisory Board. We call it our Catalyst Research Grant. It's really meant to be a seed grant, so sort of the foundation of proving early stage concepts with the hope that then that research goes on and merits much larger grants. We've been successful with this. We have provided, what we do is we provide $50,000 research grants. We have historically done that under our older program through NORD, National Organization for Rare Disorders. We've done that. We get two $50,000 research grants approved and funded and farm those out each year. This year, I'll show you in a minute, we just awarded two very exciting grants. We're hoping, don't hold me to it, it's a work in progress. I'm talking to my Scientific Advisory Board. We're looking at our current budget, but we're hoping to maybe do another grant cycle this year and give out one or two more $50,000 research grants. As I said, though, the aim of this program, seed grants to try to really foster ideas, research that looks promising. We funded a couple of research grants now for Dr. Vatanopoulos on his organoid research that has gone on now to get awarded a $2.5 million grant from National Cancer Institute. So we're very excited about that. We have funded others. There's a Dr. Flatmark in Norway who's doing some interesting work on a vaccine for PMP with a specific mutation. And we funded that early on, and now she's in the process of planning and hopefully soon beginning a early phase 1 clinical study. So this research is really focused primarily on diagnostic and therapeutic advances for appendiceal cancer. To date, we've got almost $1.7 million in research grants, 36 research grants, and that's across the globe. The two most recent grants that we just awarded last month, you can see here, one is Dr. Flatmark in Norway that I just mentioned, working on a vaccine for PMP that carries a fairly common mutation, a GNAS mutation, that to date has not really been able to be targeted. And, you know, that's a shame because it is a fairly common mutation. So we're watching that with eager eyes. And so we've given her another research grant to hopefully get that phase 1 clinical study off the ground. And our second grant that we awarded this year is Dr. Foote at Memorial Sloan Kettering. He's doing some interesting work, a really deep dive analysis on tumor tissue to take a close look at molecular predictors of appendiceal adenocarcinoma, specifically looking at the evolution of that tumor and the treatment response. In addition, just to give you a little flavor of what we're doing on the research grant side, we issued a $25,000 research grant at this year's Society for Surgical Oncology conference. This was a Young Investigator Award. And what we're really excited about with this award is this award, was created at our funding to focus specifically on appendiceal cancers and peritoneal surface malignancies. So this award went to a young investigator at City of Hope on some very cool and promising technology directed at appendix cancer photoimmunotherapy, which kind of in a nutshell, you could think about as kind of a drug, using drugs, monoclonal antibodies to specific that are activated by light, by near infrared light. So you kind of put that combination of the drug and the light to go after and target and destroy cancer cells. So that's very interesting. We're keeping an eye on that. And then, just as another example, we gave a letter of support to ASCO, the American Society, their big conference, the Conquer Cancer Foundation. And we gave a letter of support to Dr. John Paul Shen, and he ultimately then got that award. It's a $230,000 research grant. And what he's looking at there is developing appendix cancer specific chemotherapy. He will be speaking for us at a webinar coming up in June 22nd. Anybody interested in that, please go to our website. You could register, www.acpmp.org. He's just come out, he and his team, with an interesting paper looking at some questions around the efficacy of the standard colorectal chemotherapy regimen that we have all used historically, looking at the efficacy of that with some of the low-grade appendix cancers. And so he's doing a lot of research trying to think about what chemotherapy regimens might we be thinking about going forward that could be more specific and more efficacious with appendix cancer. We have an education program. Remember that one of our missions, we're really into big believers in that knowledge is power, and patient empowerment is really what we strive for. So on that educational arm of our mission, we had our big annual multi-regional symposium focused on appendix cancer. We had that in October 2022. We're already planning now our next one, which will be early November 2023. We're thinking November 3rd. That's kind of penciled in, but we'll be developing that over the next few weeks. So hold that date. I think November 3rd should be a safe one to hold. We have a all-day program with everything from soup to nuts, that for newly diagnosed patients getting ready for CRS HIPEC, that for patients with recurrences, patients that have been deemed inoperable. We really try to tackle as much information for as diverse of an audience as possible in the appendix cancer realm. We recently, just last month, launched our monthly educational series. The focus of that really is trying to look at some of the research that's going on, some of the innovations, some of the new developments, and try to do a 90-minute webinar with a presenter on that. So as I said, last month, we had Dr. Holavati talking about a potential genetic link to appendix cancer. And then coming up June 2nd, we have Dr. Shen talking about the differences between appendiceal and colon cancer and what effect that may have on some of the colorectal chemo regimens when used for appendiceal cancer. We have recently formed an education committee. As we are lean and mean, our volunteers are precious to us. We so value the volunteers that come forward to help us out. So we have an education committee that I lead with my colleague, Alyssa Strackbine, and we have a core of about 8 volunteers on that. Right now, what we're most busy with is Appendix Cancer Awareness Month, which is August. in case any of you are not aware. And so we're working on a light up campaign to really light up as many landmarks and healthcare institutions as we can. Light up amber, which is the ribbon, official ribbon color signifying appendix cancer. And we're looking at doing a hybrid of educational and fundraising events in August. So Doctors Mogal and Cohen, be prepared to give a letter asking if there's any way that we could get your help in lighting up your campus there or some of your buildings in amber. We also have a fundraising program with a fundraising committee made up of volunteers. Our biggest activity with that actually kicked off today, and is one of the reasons I'm not there with you in person. I'm on the East Coast, but our virtual walk, it's our biggest awareness fundraising event that we have every year, kicked off today. This date has an ending the 18th. If anyone is interested in still registering for that, you have time. Due to the Canadian wildfire smoke, we decided to extend this walk to the 25th. It's a virtual walk. You can register, you can get your t-shirt, get out with your friends and family, walk anywhere you want for as little or as long as you want, and participate that way to really help us both with donations, but also to really increase awareness by getting that t-shirt on. And please take photos if you participate, send them to us at info@acpmp.org. Would love to post them. Okay. Very, very quickly, this is just a sampling of initiatives. Again, all of this in deep detail is available on our website, but we have a new patient guide that really, you know, when appendix cancer patient is newly diagnosed, we try to give them information, guidance with the help of our medical advisory board on finding the specialist, questions to ask when you're talking to the specialist, things like that. We have a clinical trial repository that I now have a group of volunteers forming to help me refresh and keep updated. It's a lot of work, but it's such an important tool. We get a lot of phone calls where patients are looking for clinical trials. And so this is a repository that we try to make available, again, with the idea that knowledge is power. We have a patient registry. This is a natural history study that I am working with NORD, again, National Organization for Rare Diseases. It's on their I Am Rare platform. It is just about ready to launch. We're hoping to launch it by early fall. This is a first of its kind patient-driven repository of data containing modules from early on epidemiological, lifestyle, environmental, through the patient's diagnostic odyssey to the time of actual correct diagnosis, to treatment. There's a treatment module, a post-treatment module, and a kind of quality of life surveillance piece to this. The point of this is really to gather as much data as possible on appendix cancer patients, again, soup to nuts, so that then researchers can use de-identified, it is de-identified data, all confidentially protected, no personal health information disclosed, but to really try to make available to researchers a massive amount of data so we can really propel forward on coming up with additional treatments. We love our surgical oncologists. We're so very grateful for CRS HIPEC. It saved my spouse's life and so many others, but we also really want to get new treatments for those patients for whom that's not an option. We have the Find a Specialist map. You can plug in to where you are, your zip code, and get a list of specialists in appendix cancer. Most of them are on the surgical oncology side, but they can also direct you to their medical oncology counterpart if that is warranted. And then we have a published research repository, a repository of a lot of different scientific publications. We try to keep up with that as
Deborah, can I interrupt you for a second,
Sure.
please? We
Yes.
are running short of time and we have folks on Zoom waiting.
Perfect.
Would I request you to just send us some information that we can send to our attendees? So in the interest
Sure,
of time, we can move forward.
Absolutely. I
you.
think I'm about out of slides anyway. This is it. We talked about fundraising. We talked
Thank
about
you.
the volunteers. Let's be social. And that's it. This is the back of our shirt. Together we're stronger. We're walking towards a cure. Thank you very much.
Thank you.
Thank you, Deborah. Yeah, if you send us the slides, we'll be sure to distribute to the mailing list. Next, I'm happy to introduce Adele Jasion. Who's the president of PMP PALS, also one of our partner organizations, and she's going to give you a little bit of background on her organization and involvement in the cause.
I am so excited to be here in person. I mean, for those of you that I've met so far, it's been a pleasure. So, and it's been my privilege to meet some of the new patients and to meet the medical specialist here at Fred Hutch. As Dr. mentioned, I'm Adele Jason. I'm a volunteer with PMP PALS, but I'm also our current board president. PMP PALS is the world's oldest global volunteer-run organization, giving hope to patients and caregivers fighting appendix cancer, also known as that mouthful pseudomyxoma peritonei or PMP. And we talk a lot about the physical journey is tough, but the emotional journey is not to be underestimated. And what we do is we provide hope, support. We're here for patients here and now, dealing with that, the emotional aspect of things. So as I mentioned, we're the world's oldest. We are honoring 25 years of providing hope to patients. A little bit about our history. Our organization was founded by a woman named Gabriella Graham. She founded the organization in 1998, along with various others. Did I mess up? No. Thank you. To provide information, hope, and support. Another theme of today has been finding a specialist, going to the experts, going to people that know how to treat this. And thinking of 1998, when maybe the internet wasn't as available, people weren't as fluent at it. And so she put together this organization serving patients in 55 countries and in 12 languages. Gabriella had annual conferences, spoke at various events across the country, and really became a recognized force in this space. She passed away in 2014, and so her legacy continues by those of us who benefited from all of her efforts. I'm also a patient, so I had my CRS HIPEC over 11 and a half years ago, and thank you. Thank you. So I know without the information and support that she provided, I wouldn't have had the outcome that I have today. And so, we're volunteers and we're just committed to carrying on the legacy. Okay, now I don't know how to fix it. Thank you. So our leadership team today, again, totally volunteer driven. We don't have any employees, comprised of survivors and caregivers that offer support. As I mentioned, I'm the board president. My colleague Charmaine Skillman is the treasurer secretary, another board member, Mark McMahon, and numerous key volunteers. And if you can hear me out there, Connie, let's see, Jamie, Misty, Linda, James, Lindsay, Tara. Those are just a few, but we have many people. And one of our, we have several programs, but our two most popular are what we call our Hope Zoom program. And COVID forced us into this, where we have twice weekly Hope Zoom calls with patients. We get together, go around, people share their stories, and everywhere from newly diagnosed to veterans. Certainly anyone is welcome to join. And as we follow patients through the journey, we learn so much from each other. And again, it's not just the surgical element. Nutrition comes up all the time. Palliative care, understanding, what palliative care is, and really just different sources of information and support for each of us, and noting that we're not alone. Our card program that Gabriella had started, we send cards to patients that need that note. And when you're going through surgery, there's nothing more overwhelming than getting cards literally from people around the world that are saying, I understand, I'm here for you, we have hope for you. And so, certainly you can sign up for our Hope Zoom calls on our website, and also for our card list. Bears, we have a longtime volunteer, Linda, that has been sending these bears to patients when they're in the hospital. And it's just a little token, a little reminder that, again, you're not alone. We're here. We provide one-on-one mentoring support in addition to the group support that we provide through Hope Zoom. Answer questions through info@pmppals.net. We're on social media, daily information, inspiration, event registration. Our website has a variety of sections with information, dedicated to providing patients and caregivers really the information that they need. A lot of our more technical sessions are taped, and so we have all those videos out on our website. Our impact for 2022, we've had 95 Hope Zoom meetings with over 2,600 attendees. 9 of those were specialist, presentations. We've sent approximately 2,000 cards and bears to patients. We have a caregiver panel. Caregiver journey is a little different than the patient journey, but just as important, and ongoing support. As I mentioned, we're volunteers, totally donation driven. And, the invitation for everyone here listening today, if you're a patient, join us for a Hope Zoom meeting, visit our website, sign up for our newsletter, follow us on Facebook. If you're a medical professional, sign up for our quarterly physician newsletter. Make sure you're also listed on our site. Volunteer to present at one of our Hope Zoom sessions, and then connect with us on LinkedIn. Hope is our middle name. That this is what we do. We know what it's like. We all do this because somebody did it for us. And every journey is different, but there's power in the support, and also now if you want to give support, there's something therapeutic about being able to give support and share your story. We invite you to volunteer with us and help us any way you can. But as I said, I'm excited to be here. I'm excited to meet all of you. And, for everyone here at Fred Hutch, Dr. Mogal, Dr. Cohen, and everyone else, thank you for the invitation.
All right. Thank you so much. That was awesome. Some great information up there. Are we going to go to the last PowerPoint? No. I'm supposed to know how to do this, presumably. All right, so just in the last couple of minutes, I'll try to be ahead of schedule here. More meant as an overview, but actually Dr. Cohen, again, who unfortunately wanted to be here, but is not, just got back, as you've heard, from one of our big cancer meetings for the season called ASCO. And we wanted to give a clinical trials update, both from there and also what's going on at Fred Hutch. Do we have the slides or no?
I think Dr. Cohen has them. So
Go back to the list. She's not on.
No.
Hers aren't on here at all.
No.
Yeah. Okay.
So,
Well, she's not on, so that's going to be difficult. Well, I have looked at the slides, so I can, while we're kind of working on getting those up. The first couple actually are more informative, so if we do have a minute, maybe if you can get to email or anything like that on here. So one of the main messages when thinking about clinical trials, because obviously as this is a patient event, a lot of people will have questions related to that. You know, we have information for clinical trials on our webpage at fredhutchcancercenter.org and also through the GI medical oncology webpage in particular. And the first slide was really just a picture of clinicaltrials.gov. That's really probably the most up-to-date and accurate source of information for what trials are open and accruing at any given center across the country or actually even the world, but particularly for Fred Hutch. And it changes pretty rapidly, but that has to get updated, not in real time, but pretty close to real time. So always a good reference. The second thing that Dr. Cohen wanted to talk about, and I think is worth at least just spending a couple minutes on, is really just kind of the breakdown of clinical trials. And I know we're over, so I don't want to spend too much time, but when looking at clinical trials for therapies or surgery or whatever we might be studying, there's multiple phases that we have. So we consider phase 1, phase 2, phase 3 clinical trials. And the expectation for the patient is going to differ a little bit for each one. So it's important to kind of know what those all mean. So phase 1, when we say that, typically is a safety trial. So these are really the newest drugs perhaps that are coming, or the newest treatments that are coming available to human use and are often the first in human type of trials. And the goal of those trials is really to provide a safety analysis of that new therapy. And so a lot of times they'll be for treatments that haven't been used, as I mentioned, and a lot of times they won't specify one disease that we're looking to treat them in, but we don't know, maybe there's a signal in any number of diseases. So there may be a larger group of diagnoses that we can include. And there'll be, so this is the clinicaltrials.gov website, and now I'm talking about the phases. So we'll look to basically learn that it's safe in various people. Phase 2, often if there's a signal out of phase 1 studies, or if there's specific mechanistic reasons why a drug or therapy might work on a particular type of cancer, phase 2 study will have a little bit larger group of people, usually a specific diagnosis. This is often single arm, so everyone gets the drug. You know, you're gonna have that as part of the clinical study, although they can be randomized on certain occasions. But there's not a large track record of that particular medication or therapy in the diagnosis that we're giving it. So we're really looking to determine if it's efficacious or not. Obviously, with the rationale and expectation that, you know, we hope it would be. Phase 3, when you're looking at clinical trials, are generally the randomized control trials. So I think the most important thing for patients to know is that usually there's a randomization between either the trial investigatory drug or either standard of care, which often is even placebo. So it's really a maybe of whether you're going to actually receive the study drug. There's often an opportunity to cross over after you've been on a study for a period of time and actually be guaranteed to have the drug or whatever the therapy is. But those are usually compared to a standard of care. So the idea being that it's truly a question of whether the new thing versus the standard is better. And so, you know, from a patient perspective, you know, you're at least going to get the best thing that's out there, but you might be getting something potentially better. So with that background, this is not meant to be an exhaustive overview, but just for our patients that are here today, just to share some of the potential studies that are open at Fred Hutch. So a lot of these, actually, there's been a lot of questions in the chat about specific mutations. So The top couple studies, the first one is waiting list only. We're waiting. This is a nucleoside analog versus with irinotecan, which you've heard is one of our standard chemotherapy agents. It's waiting list only. Some of the Elevate trial is a phase 2. So again, you'll see these labels in here. That's using in second line. It's again a standard FOLFIRI plus Avastin with this new CD47 regulator, which is affects macrophages. We have a couple of studies for BRAF, KRAS, and HER2 mutations, which are common mutations in colorectal cancer. And so these may be ones that if you're being treated here at Fred Hutch are good to talk to with your medical oncologist about the possibility of having inclusion in these. I won't go through the specifics of each one just because of time constraints. Again, I mentioned phase 1 in particular tends to change very rapidly. So there's actually no phase 1 trials at the moment that for any of the diagnoses that we're discussing today, but would definitely recommend checking back often and speaking with medical oncology at any visits. Couple updates from ASCO. These are more pertinent to the peritoneal malignancy group. So Radspherin, these are intraperitoneal radioactive particles that have been delivered in a phase 1 study to this point. These are from Norway. It's unfortunately not something that we offer here. We're not one of the treating centers, but just to show that there are kind of new ways that we're seeing to treat peritoneal disease. A lot of these are advanced patients who wouldn't necessarily be able to undergo surgery for cytoreduction. So it's good to know that there's kind of new therapies and new drugs coming down the pipeline. This was shown to be safe. There was some signal in terms of response, but we need to let the data mature before we can speak too much about it. There was a question earlier about HIPEC, and that's probably something when you come to this event next year that we'll hopefully have a little bit more to speak about. But it's a newer type of intraperitoneal chemotherapy or intraperitoneal therapy, which instead of the traditional HIPEC, which we've described, uses a liquid form of chemotherapy that's instilled into the abdominal cavity. This is basically an aerosolized chemotherapeutic agent, or there's a few different things that can be administered, but currently there's a few systems we know. The first one listed here is called Elicetra. This is an Israeli system where there is actually a biologic installation of engineered macrophages that are kind of doing like an immunotherapy type of treatment. That again is just in phase 1 study in Israel at the moment, but is something that may be available in the United States or more broadly in the future. The phase 1 trial of City of Hope is more similar. It's more similar to the aerosolized version of the medications that we're familiar with, chemotherapeutic agents. We are actually part of the list of centers that will likely be included in the phase 2 trial from City of Hope, and we hope that will be sometime within this year. But again, it'd be a new program for us and something we're working to bring here. At this point, HIPEC is really for the advanced stage. So there's a lot of kind of, just to kind of address the question specifically, there's a lot of constraints that don't allow HIPEC to be used with cytoreduction or significant cytoreduction at this stage in the United States. And a lot of it is because we're trying to prove that it works, and we want to make sure that we're doing it as safely as possible. And so combining it with a large operation is, it gives the potential to hurt that safety profile. But we have seen good signals coming from Europe for that particular type of administration. This is just a small plug for a small grant that we've gotten within our group that we actually, for anyone undergoing cytoreduction or HIPEC, we're able to biobank, and this is to be able to do translational studies in the future. And so that's for any diagnosis, and specifically for colorectal cancer. The idea behind this project was to create a tumor model called slice culture that we can actually kind of start characterizing some of the microenvironment and immune microenvironment for colorectal cancer that's metastasized to the peritoneal cavity. So more for people who haven't undergone surgery yet, but it's something that we're looking to definitely study here at Fred Hutch. Additional trials that are also open at Fred Hutch include acupuncture. This is kind of a correlative study for what the impacts are on some of the side effects that oxaliplatin may have. I do believe you have to be undergoing oxaliplatin therapy at the time to enroll in this trial. Dr. Cohen leads a peritoneal washings study that is related to colorectal cancer again, and is looking to identify biomarkers at the time of initial colorectal surgery. And there's also a couple of different efforts that she kind of touched on here, investigating ctDNA similarly in colorectal cancer, both local disease also and also in the metastatic setting, like in the peritoneum. So these are things that you should be asking about at medical oncology appointments, and hopefully would have something to offer. I think that's the end of this talk, and then we just wanted to bring up one more slide.
All right, I know we are really out of time, but where's the, did you already get to that?
Oh, yeah.
Yeah. I think you already opened it, didn't you? But I would be remiss if I didn't acknowledge a few people, so bear with me for 2 seconds. So obviously the effort that we put forth, within our programs, it really truly takes a village to get patients through the whole spectrum of all their treatments. And I would be remiss if I didn't acknowledge, this is very, very small fraction of the people that are actually involved in the care. You see a lot of people behind you. There are lots of people behind the scenes. So, and we really appreciate everybody who thanks them for the care, thanks them for the work they do, especially folks that are not patient facing directly. So thank you for doing that. I want to quickly also introduce Ginny Tranglu. She's here today with us. Ginny actually flew all the way from Delaware. She actually is a new member of our team who's going to be joining our HIPEC program starting August or September, I think. And we're very excited to have her as an advanced practice provider who will be helping with a lot of our patients, especially when it comes to postoperative management and surveillance and things like that. So welcome, Ginny, as part of the family. And with that, one more, sorry. And big round of applause to our team that really worked hard to put together this conference. I mean, the first time we ever did this, we asked Fred Hutch, we had no questions asked. They said we would 100% support this venture. Ritu, Meredith, Cody, your whole team, thank you for this incredible effort that you've put together. It takes a lot of planning, as you can imagine. And I would appreciate if everybody could give them a big round of applause. And with that, if you have questions, please don't hesitate to reach out. Please fill out the survey. We really want to know what you'd like for us to speak about. We can't cover every topic in peritoneal malignancy, but we would love to incorporate topics that you're passionate to learn more about. And then please wait for 2 more minutes. We have our photographer here. We'll take a quick picture and then everyone can go and enjoy the rest of your day. Thank you. And all the Zoom participants, thank you for joining virtually and spending your time with us this morning.